वो अनम्यूट है।
नहीं, I can see she is muted.
आप पूछ सकती हैं, आपकी आवाज जा रही है।
हाँ,
आपकी आवाज जा रही है।
नाम बोलिए, वो एड्रेस कीजिए।
welcome Dr. Yanja.
Hello.
Yes, Dr. Yanja. Yeah.
Yes.
So,
Hello.
welcome Dr. Yanja. Our health minister is soon arriving. He is reaching. He is on time. So I know it is 12:30 in the night there.
It's okay. That's all right. We'll wait.
Okay. Thank you so much. So Dr. Ravi, hello.
Yes.
Can you hear
Hello.
us? Okay.
Yes.
And Dr. Pooja?
Yes, Dr. Cash. Yeah.
Okay. Where are you? I can't see her. I can't see Dr. Pooja. Yes. Okay. So it's midnight. I really appreciate your effort. So just wait for a few seconds. Our minister is reaching. He is on time. So we will be starting, and first there will be address of our national president, just 2-3 minutes, our honorable additional chief secretary. And then we have our National Health Mission Director with us. This is just informal. He is Dr. Ravi Shankar Shukla. He is a very brilliant young IS officer, and all the connectivity he has done. Last time also he only did it, but he was physically not present. This time he is physically present. Ravi Shankar, ji, say hello.
Well, welcome all the participants.
So she is Dr. Pooja. She is a pediatric cardiologist in University of Texas. He is Dr. Ravi. He is a critical care head in University of Illinois. And she is Dr. Yanja Bullet. She is a very senior pediatric ICU expert in UCLA, University of California and Los Angeles.
Welcome, and we are really very thankful for finding time to address the doctors from across the state who are really in need of such training and such discourse. So once again, big thanks to all of you, please.
Thank you.
Thank you.
We will formally start, Dr. Yanja. We will formally start once the minister reaches. He has already reached the premises. Okay. And our national president, Dr. Jaya Lal, and our National Indian Medical Association Secretary, Dr. Jayesh Lele is there. Our state president, Dr. Arun Singh sir. Good morning, sir. He is muted. Dr. L. Ishoda, madam, good morning. She is our Women Doctors Wing National President.
Good morning, ma'am.
Yes, Dr. L. Ishoda, madam, is there. She is our National President, Women Doctors Wing IMA. And I can see one more doctor. So, Dr. Divakar, the head pediatrician of PMH, have you joined? So, I have invited Dr. Divakar and Dr. Ravi Ranjan also, Dr. Ravi Ranjan also for discussing, as discussed. So, Dr. Divakar ko lagao, have you joined? Co-host banana hoga. Dr. Ravi Ranjan and Dr. Divakar. Madam, Minister is just reaching. The Minister is just reaching. So, we are on time today. Nahi, pediatrics. Dr. Divakar ko lagao, pediatrics. He is more important. PAED, Dr. Divakar.
Dr. Bhardi. Dr. Bhardi.
Yes, madam.
HSC दोनों आ गए.
The President Jayalal sir and Secretary Jayesh Reddy sir have joined. Let's see.
Join. They have joined. Bhardi आ गए हो.
Okay, madam, I'm just waiting for the honorable minister, because once the minister comes, then I will start the formal with everything. Welcome our honorable president, National IMA, Dr. Jayalal sir. But sir is not, I welcome our state secretary, Dr. Pradeep Singh. Sir, are you audible? Are we audible?
Dr. Mani.
We welcome our additional chief secretary, Arun Singh sir.
Good morning.
Sir, good morning, good morning. Are you looking very fresh? All over the screen.
तो मंत्री जी कब पहुंच रहे हैं?
मंत्री जी आ गए हैं, पता नहीं कहाँ चले गए। लगाओ जरा संजय पन्ना को। So, sir, Dr. Yonja Bullet from UCLA has joined. Dr. Yonja Bullet, Dr. Pooja from University of Texas, and Dr. Ravi from University of Illinois. Our additional secretary, Honorable Arun Singh ji, is there. संजय बोला क्या सर इतना लेट होता है?
bedroom light charger
Should we start? You have unmuted. So, are we audible? Please unmute the speaker and the guests.
Yes.
Yes.
Okay, so Yonda, are we audible?
Yes, I can hear you well.
Dr. Pooja, are we audible? Okay. So on behalf of Women Doctors Wing, IMA Jharkhand, I welcome to the first international webinar where specialists from top medical colleges in USA have been requested to share their insight and perspectives on combating a possible third COVID wave that is projected to affect several lakh children in Jharkhand. This is the first time that such an international collaboration between top US-based doctors with their counterparts in Jharkhand has been attempted to identify early warning symptoms in children, which is different from adults, as well as drawing up treatment protocols, identifying needed infrastructure to be put in place, providing training to the doctors and the health workers to save our children and the future. I welcome Honorable Health Minister Shri Banna Gupta ji in this COVID-19 third wave international pediatric ICU and critical care training symposium. He is the source of inspiration and a guiding force behind this program. And on Sunday, he has traveled so far from his hometown. We really thank him. We are thankful, sir. I welcome Honorable Additional Chief Secretary Jharkhand, Mr. Arun Kumar Singh. He has joined from Delhi. I welcome our National President, Mr. J.A. Jayalal, sir. I welcome our National Secretary, Indian Medical Association, Dr. Jayesh Lele, sir. I welcome all the special invitees, National President, WDW, IMA, Dr. L. Yashoda, National Secretary, Dr. Kavita Ravi, our State President, Dr. Arun Singh, and the State Secretary, Dr. Pradeep Singh. I also welcome our eminent international speakers, Dr. Yonja Bullet from University of California and Los Angeles, Dr. Ravi Kashyap from University of Illinois, USA, Dr. Pooja Kashyap from University of Texas, USA, who have taken their precious time out during odd hours for our state as it is almost midnight in USA. We welcome all the civil surgeons, physicians, pediatricians in this International Pediatric ICU and Critical Care Training Symposium. We welcome Dr. Divakar from TMH, he is head of pediatrics. Dr. Ravi Ranjan, he is head in Tata Motors in pediatrics as discussant. Now, before I invite Dr. J.A. Jayalal, our Honorable National President IMA, to address, I invite our State President, Dr. Arun Singh, to introduce Dr. J.A. Jayalal, sir. Over to Arun Singh, sir.
Thank you, Bharti. I feel honored to honor our guest of honor, most dynamic personality, Dr. J.A. Jayalal. He is the National President of the Indian Medical Association and National Head of IMA UNESCO Bioethics Chair. He is MS FRCR from Glasgow University, has done DLS in Germany, FIGES MBA and PhD surgery. He is a renowned laparoscopic surgeon. He is Professor of Surgery, Kanyakumari Medical College Hospital, and he is a really dynamic personality. He has done he is doing a lot of things for the medical fraternity of the country as well as for the global community. Thank you, sir. Welcome, sir. Hello, Bharti.
Thank you.
Yes, sir. Yes, sir. We can hear
Thank
you,
you,
sir.
Bharti, beloved and distinguished Minister of the Health of the State of Jharkhand, the Additional Chief Secretary, the President of Indian Medical Association Jharkhand, and the Women Doctors Wing, the National Chairman Dr. Yashoda, and the Jharkhand Chairperson Dr. Bharti, and distinguished members of Indian Medical Association and the learned colleagues in the medical profession. I'm extremely happy and delighted to be with you at this moment, especially in the presence of our Honorable Health Minister. I am so thankful to the Honorable Health Minister and the Ministry of Jharkhand, the Chief Minister, for always being careful caring enough to support the medical profession and also for the welfare of the community doing human services. The enormous service, enormous work which you have done to the society and building an awareness on the people has been well exemplified and were able to see in the COVID care, which is the state of Jharkhand is always in the top state where we are able to control and build awareness and bring down the mortality and help the medical professional to go forward. I am extremely happy on this day. We just celebrated the Doctor's Day, and which Dr. B.C. Roy, in whose remembrance we always celebrate this Doctor's Day, he used to say one word very repeatedly: whatever thy hand doeth, do it with full heart, full passion, and full might. That is, whether it is a small work or a big work, whether it is an awareness building or a treatment, whether it is just an OP rounds or giving a medicine, that us, V.C. Roy always emphasized, whatever you are doing, do it with your full heart and full passion and full might. I'm sure today our medical fraternity is learning that art and we are doing it with a full heart and full might. That is why today in the COVID care, India could do much better than any other country in the world. It is not for the naam ki saak. It is not for the just for the sake of that we are doctors. We felt the need and we were in the forefront and we were able to tackle the crisis very effectively from our heart, from our full our might. That is why in the country we have lost nearly 1,500 of our doctors. Though in spite of that, we have lost so much of doctors, the medical profession is able to do the service to the need of the people at all levels. But even after doing that, I know for sure that many places that violence is creeping in. The people think doctors are the soft target. They always feel doctors will not retaliate, so they will always tolerate. So that many places we are seeing violence on the doctors. So it is my humble appeal to Honorable Health Minister and Honorable the Ministry that we need to protect our saviors. We need to protect our healthcare professionals. There must be some stringent laws, stringent ways and means by which we will be able to punish those people attackers. Not only that we are intended to punish the people, but we want to prevent this to happen. To prevent this to happen, the healthcare infrastructure should have security system. If you see any National Board of Accreditation or anywhere you are rating an hospital, there are so many other laws are there, Biomedical Waste Act, Fire Safety, so many acts, but there is nothing to ensure the safety and security of the healthcare professionals are maintained. Now, throughout the India, now almost 23 states has already enacted the law. Now we are insisting on the central government to enact the law, which will encompass the central healthcare protection. But I learned to know that Jharkhand is yet to raise an act to protect our doctors. I wish an appeal on behalf of the Indian Medical Association as a president of the 3.5 lakhs doctors of this country. I appeal to our Honorable Health Minister and please give your maximum possible help to the doctors to serve this country in a fearless atmosphere. If a doctor decides that he will not take a serious case, that will be a very disastrous situation for us. I once again take this opportunity for Dr. Bharti for the enormous steps she is taking to build the awareness. I attended a meeting in which she was able to take the Anganwadi workers, Asha workers, the tribal people, and everywhere she is trying to do some of the training program. So we also, on behalf of the IMA, we assure our Honorable Health Minister, we are with the government. We are ready to handhold with the government to carry on your vision, cherished dreams to implement in the country to make all the health for all is reaching all the people. Only we want, let us work together with a common agenda that we will be able to serve something good to the society with our full heart and full passion. And for that, we need an atmosphere and environment to work without fear, without tension, without anxiety. I'm sure our Honorable Health Minister will do that help for us. So with that, I wish all the best for this program and looking forward as we are now well equipped the technology, infrastructure, manpower, and the know-how. We will be able to face the third wave with very confident. Definitely, we will make sure that our country is able to overcome the disease at appropriate time. Thank you very much for this opportunity. May God bless you all.
So now I invite Dr. Jayesh Lele, our Honorary Secretary General, Indian Medical Association. Before his address, I invite National President Women Doctors Wing IMA, National IMA, Dr. Yashodha, to introduce our National Secretary. Over to Dr. Yashodha, ma'am.
Thank you, Dr. Bharti. Namaste to all. My wishes and respects to our National President, Dr. Jailalji, Dr. Jayesh Leleji, and the Honorable Health Minister, Sri Banna Gupta ji. Namaste to all. And whatever program, जो भी program Dr. Bharti करती है, वो तो just she's my बहन. She does with बहुत प्यार और मन से full attraction और full respect से काम करती है. और जो भी प्रोग्राम वहाँ झारखंड में करती है वो तो फैलती है यहाँ से वहाँ से. और she is very conscious about her work, and I thank her for giving me this opportunity. And she is very active, and she promotes the program in a very nice manner. It's an honor for me to introduce our Jayesh Lele sir, HSG. And today this program of Department of Health and Family Welfare, along with the WDW, which is also it's a good mark for Jharkhand WDW, and along with the collaboration of University of Texas, California, conducting this program. We thank Dr. Bharti ji. Now it's such an honor for me to introduce Dr. Jayesh Lele as a guest of honor. He is the Honorary Secretary General of IMA Headquarters 2020-22, Honorary Secretary IMA HBI Hospital Board of India 2016 to 2020, President of IMA Maharashtra State, and earlier in 2015 and 16, Professor Sridhara Sharma Oration Award he has received in 2017 in recognition of services rendered to IMA headquarters. He has held various posts in IMA, IIT branch, state, and he has got a lot of awards from headquarters and IMA Maharashtra. He has also got individual community service award in 2015, and he has delivered Thane Oration CEE MapCon 2016 Aurangabad. He is also a Maharashtra Medical Council member Accreditation Committee Ethics, and gave many talks on CEE, NABH and others. Away from this, very simple person, answers every call of every member at any time of the day. Both our National President and HSC always work 24/7. At present, I being the chairperson of National WDW, we have a good support along with our National President and HSG for promoting our projects, which Dr. Bharti is also doing it. On 1st July 2021, we had the Doctor's Day celebration, and we have also inaugurated Safe Motherhood for a week, which is going on. ये तो अभी चल रहा है, every day 8 to 9 o'clock, and we have released a project called Swayam. Swayam means self, for which the breast cancer and cervical cancer awareness has been started. Our wish of headquarters and National President is there is a target of 1 million, which Dr. Bharti has promised me she is going to do it. I request all the women leaders to gear up for this project, and my wishes, my आशीर्वाद to my बहन जी Dr. Bharti, जो बहुत अच्छा काम करती है झारखंड में, ये वैसे ही कंटिन्यू करना है. Now I wish Dr. Jayesh Lele for his wisdom speech.
Thank you, Dr. Yashodha. Am I audible? Hello?
Yes, sir. You are very much audible, sir.
Yeah, thank you. Thank you so much. Respected National President, our Honorable Health Minister from Jharkhand, Additional Secretary from Jharkhand, President from the Jharkhand, Dr. Arun Kumar Singh, and Dr. Bharti Kashyap. Have gone through the entire program, and all the delegates and the international faculty today we have for this important CME. Really, it's a great work, and pediatric intensive care units are very rare to see. But now, thinking in the minds of the regarding the third wave possibilities, and thinking that children will be affected more, you have arranged this special training. And I can see Dr. Ravi Kashyap, Dr. Pooja Kashyap, and other international faculty is going to talk about this very important work. Really, Jharkhand is doing really last about 1 month back also I attended one program, and I saw that delegates were coming from all the small areas, small branches and small places like panchayats and other things. This is very important because we need to fight out this and take care about the children because they are not vaccinated. And if they get infected, if they get a critical disease, then our PICU, that is Pediatric Intensive Care Unit, would be very handy. And this has been very ably supported by women doctor wings, Dr. Yashoda and Dr. Bharti and other ladies across India. I'm sure that today's CME also will be very helpful for all of us. And I really congratulate Dr. Bharti Kashyap for arranging this very important topic. Second thing, I also request Honorable Health Minister to take care about this, act which we are thinking about, the Central Act against the violence against doctors. At the same time, the Clinical Establishment Act in Jharkhand. So these two things are very important, and I would request Health Minister particularly to look into this very important act, which are sometimes troubling the doctors day in and again. Just on the 1st July, we had a Doctor's Day, and our Honorable Prime Minister came to IMA program and addressed us. He did mention about the various issues, and I'm sure today the doctors who are last 1.5 years working very tremendously in this corona issue, like a war, and we have lost nearly 1,500 doctors in this. But still, our doctors have not ran away from the critical issues. And we are working, we will definitely continue to work. So we would request the support from the government and ministries in various subjects. Thank you so much, Dr. Bharti, our national president, and all the international faculties to join from America at this odd hour. I can imagine Texas. Texas is just now midnight because my daughter stays in Texas, and this is the midnight. I spoke to her in the morning. California, again, it is around 9 o'clock, I think so. So really, it's a hats off to the international faculty for joining at this hour. Thank you so much. God bless. Over to Bharti.
Thank you, sir. Thank you so much. So now I invite our Honorable Additional Chief Secretary Jharkhand, Shri Arun Kumar Singh, for his address. Over to you, sir. Over to Dr. Arun Singh, sir.
Thank you, Bharti ji. It has been an honor for me to attend this international seminar on third wave PICU and critical care training and preparation of the pediatric ICU. Save our children, protect our future. First, I would like to congratulate all the doctors on belatedly though for the Doctors' Day, which was on 1st of July. They have done a great job so far across the country, especially in Jharkhand. And I'm quite honored to see Dr. Ravi Kashyap, Dr. Pooja Kashyap, who are, as Dr. Jayesh Lele elaborated, that they are sitting amidst night to attend this seminar that reflects their love for the country. We are very lucky to have Mr. Banna Gupta ji, who is our Honorable Minister of Health and who has been our source of inspiration, and he has guided us all along, keeps on motivating us, keeps on motivating all the doctors. Dr. Jayalal and Dr. Jayesh Lele, our IMA President, Dr. Arun Kumar Singh, and all the participants who are participating in this international conference. The topic today is very relevant And first, I would like to elaborate regarding the status of the second wave, which has affected the state. The second wave was quite severe. The first wave was from 31st March last year till 15th March of this year. And we had around 1.2 lakh positive patients. And we had 1,093 deaths. Against that, within a span of around 3 months, we had 2.19 lakh more positive patients and deaths were around 4,000. Overall deaths in the state are around 5,100. The positivity rate compared to the national standard is less now. We have 3.44 positivity as compared to the national 7.35. Fatality rate though is a bit more because the positivity is less. Every day we are conducting around 50,000 tests. Recovery rate is 98.27, which is much better than the state, the national average. During the second wave, the state took a lot of initiatives and we increased the number of oxygen beds from around 1,400 to around 15,000 within a span of 2 months. The number of ICU beds were also increased from 400 to around 1,378. And the ventilators supported bed also increased from around 300 to 865. We have started installing around 60 PSA plants in our state in various hospitals, especially the public hospitals, to prevent any chance of any shortage of oxygen in the state, though Jharkhand has been the state which has supplied oxygen to around 16 states as well as to Nepal during this pandemic. For preparation regarding the third wave, as far as the target and the magnitude of the issue is concerned, and as is being anticipated that people below the age of 18 would be more susceptible to third wave since they have not yet been vaccinated. The government is already conducting its tests for vaccinating the population below 18 years. We have around 1.43 crore population below 18. And if we take positivity at 5% and around 7 lakh people would be affected. And if 40% are symptomatic, then it will be around 2.9. And based upon that formula, we'll have those who are severely affected would be around 9,000. And moderate would be around 43,000 if this wave comes. We have already started preparing for the third wave. The training of doctors, because we are running short of pediatricians in the state. We have started training of the other doctors, and training is already going on in our Center of Excellence, RIMS, Rani Hospital, and TMH in Jamshedpur. The paramedical staff is also being mobilized so that we don't have any shortage, as we expressed and felt in during the second wave. The infrastructure is also beefed up. We are also procuring ambulances, especially for the children. 24 ambulances we will be procuring for children in each district. We will be having one ambulance, and if required, then we will go for more. Medicines also are being procured. Equipments, especially the ventilators for the children and other medical equipment is also being procured. I had a opportunity to attend the national meeting on the Ayushman Bharat just a day back, and the government of India has increased the cost of package for Ayushman Bharat so that the beneficiaries who were deprived of being covered under Ayushman would now be covered. The cost has been increased. I also requested to include the multi-organ inflammatory syndrome in children in that package, and that has also been included. Dr. Bharti Kashyap would be pleased to know that, and even all other doctors. The strategy now is to prevent third wave, and for that we have to beef up our facilities and prevent the spread, because right now we have around only 830 cases in the state, active cases. And out of these active cases, 222 are symptomatic, rest are asymptomatic. So it is very less and very manageable. We have taken certain strong steps so that the testing at the entry points, especially at the railway station, at the airports, and on the roads, the national highways and highways which are entering our state, the testing has been beefed up so that we don't leave anybody who's coming from outside, because now the threat is from outside, because since, as I told you, the positivity is quite low, and every day also we are getting less than 100 positive cases. Only 222 are symptomatic. So the strategy is to test and to isolate those who are positive, and they should be mandatorily be quarantined and isolated in the hospital. We are also stressing upon tracking after this testing, tracking with whom all these positive patients came into contact, so that we don't leave any chance of any positive person roaming around freely. And then the strategy of treating them, as I told you. As far as vaccination is concerned, the state has taken a lot of initiative, and our vaccination rate has now increased to around 1.25 lakhs per day, which was around 30,000, 40,000. Around 70 lakh population has been vaccinated. And we hope that if we get vaccines in time, since it is being supplied by Government of India, we have capacity to go to around 3 lakhs per day. Because once a momentum is built up, and if there is shortage of vaccine, then it becomes difficult to sustain that momentum. So we are stressing upon Government of India so that we get vaccines, sufficient supplies of vaccines, so that we can accelerate this vaccination drive and ensure that our citizens are protected and shielded. For enforcing the COVID appropriate behaviors, we have come up with a strategy of community policing, which is now being in the initial stages and would be exercised in greater proposition. Yesterday in Delhi also I found that at each and every crossings on the road, people and policemen and people with the identity were stressing upon those and even fining those persons who were not even having masks. So this mask, social distancing and sanitization, the SMS, social distancing, masking and sanitization. This SMS is very, very critical as far as COVID appropriate behavior is concerned. So we are focusing on these strategies so that we don't allow the third wave to come, but to prepare ourselves from any eventuality. As I elaborated, we have taken all necessary steps. I presented, the Jharkhand government has prepared, it was the first state in the country to prepare the document, the manual for handling and tackling this third wave. And after that, Government of India also came up with that. We were the first state to organize a national webinar on this, which had all specialist doctors. And when I presented this manual to Honorable Central Minister Dr. Harshvardhan, he said that he doesn't believe in third wave. He said it is a useless document. Useless document. I told him that this document basically is a preventive document. We cannot be casual and lethargic and ignorant. We have to be alert. We should not be caught off guard. So if we are prepared, and even if third wave doesn't come, it doesn't make any loss to us. We prepare and beef up our infrastructure, manpower, resources, medicines. In fact, taking advantage of this COVID, we have started improving our hospital management. Also, every day we are getting reports from our public hospitals, and it has started showing results also. Dr. Bharti Kashyap and Dr. Jayesh Lele, they raised the issue of protection of doctors against any untoward incident. And you would be pleased to know that I already requested Dr. Bharti Kashyap that if, and other doctors of IMA, if a standard document or any document of any state is made available to us, since the lead has already been taken by certain states, we won't lag behind, and you need not make any request to us for making this, because you are part of our team. And we consider you as a very valuable resource, and we would take all steps to protect. You should not be worried at all. No doctor should worry. We are always behind them, always willing to support them, and will not leave any stone unturned in ensuring their protection. So very soon we will be having the protective mechanism in place, though we had already issued a notification in that regard around 6 or 7 months back. But if any more teeth is to be added, we'll add that to that. So as I elaborated, we are prepared. We have taken a lot of steps, and I'm quite hopeful that today's deliberation would also strengthen the intention and the commitment of all the doctors who are participating. Our civil surgeons are participating, and we would ensure that we will not allow the third wave to enter our state. And even if somebody comes to be affected from third wave, then we'll take adequate steps to treat and ensure that nobody dies. We had a bad experience of mucormycosis. Around 152 persons have been identified, out of which 86 are diagnosed and 66 are not clear whether it is a case of mucormycosis. 26 of our valuable lives of patients suffering from mucormycosis have been lost. But the government has declared this as a epidemic, and we are taking all steps to prevent any more loss of life as far as mucormycosis is concerned. So this is what is my submission, and I thank Dr. Bharti Kashyap for organizing, taking the lead, and she has been a very, very active person, full of enthusiasm. I wish you all good luck, and hope that this seminar would strengthen us and make us more committed towards handling this third wave. Thank you very much.
Sir, so we are, thank you, sir. Thank you so much for your blessings. And before we are going to start. So our secretary, Dr. Pradeep Singh, sir, are you here? He's muted. So he is there. He is muted, I think. So please unmute कर दीजिए उनको.
Thank you very much, Dr. Bharti, for organizing International Symposium on PICU and critical care. My best wishes.
Thank you, sir.
For this success of this symposium. Thank you very much once again.
Thank you, sir. So now we are going to start the first session of 15 minutes in which Dr. Ravi Kashyap, Associate Professor from University of Illinois, would be presenting COVID-19 third wave. Is it preventable? Emergency triage and assessment of work of breathing in detail. Adult COVID-19 presentation. Is it different from children? Importance of early recognition and transfer to pediatric ICU, intermediate care center. So over to you, Dr. Ravi. So we have not introduced Dr. Ravi. We know Dr. Ravi is the associate professor in the University of Illinois. So, okay, please start.
Thank you so much. In the interest of time, I would like to thank Dr. Bharti Kashyap to organize such an important topic today and allowing me to be a part of it. I'd like to have special thanks for Honorable Health Minister Shri Banna Gupta, Honorable Health Secretary Dr. Arun Kumar Singh, and very good speech. He pretty much covered what I'm going to talk about today, so that's great. I'd like to welcome again National President of Indian Medical Association, Dr. J. Jayalal, Honorable Secretary General, Indian Medical Association, Dr. Jayesh Lele, and NHM Director, Ravi Shankar Shukla. So as I said, honestly, Dr. Arun Kumar Singh has pretty much covered very well what I'm going to talk about today. And I was happy to see that if I had anything to suggest, he has it covered. So with that, as he mentioned that, we have just been gone through the second wave, and obviously, we are preparing for the third wave. And I'm very proud and very happy to see that the government of Jharkhand, as well as the healthcare providers of Jharkhand, are so proactive. Be prepared, as Dr. Arun Kumar Singh said, that yes, we hope that third wave would not come, but we need to be prepared. So I totally agree with him. So with that, is it preventable? Is a third wave preventable? Well, we definitely need to try, right? So if I can sum up my talk today in 3 words, that'll be vaccination, vaccination, and precautions. So about the vaccines, what do we know? What do you know for sure what's happening? So COVID-19 vaccines are safe and effective at preventing COVID-19 disease, especially severe illness and death. Recently, one of the studies came out from month of May in US. Almost all the deaths due to the COVID-19 infection was in the patients who were not vaccinated. And in my personal experience in my own hospital, we have been kind of watching it since January of this year. Only one person in my intensive care unit has died due to COVID-19 infection who was vaccinated. Everybody else was not vaccinated. Additionally, what we are seeing again in our own hospital, 95% of the hospitalized patients with COVID-19 infection were not vaccinated. So clearly shows that no ifs, no buts, the vaccines are effective, no question about it. Additionally, the COVID-19 vaccines reduce the risk of people spreading the virus causing COVID-19. So not only it is helping to save the patient's lives, but the people who have been vaccinated, they're also helpful in not spreading the infection. And that will help us to prevent the third wave. We all know there could be some side effects after vaccination. These are mild and usually they go away within few days. It typically takes about 2 weeks after vaccination for the body to develop the immunity. We know that against the virus. Now, the person is not considered fully vaccinated until 2 weeks after the second dose of a 2-dose vaccine or 2 weeks after a single-dose vaccine. Now, what are we still learning? There are a few things we're still learning. How will the vaccines protect the people with weakened immunities, immunocompromised systems, including people who take medicine that suppress the immune systems? So, for example, transplant patients or somebody is requiring the immunosuppressant. We don't know for sure, but the signal so far shows that the likelihood is that the vaccines are helping to protect these patients as well. Again, we're still learning about that. So now other things we're trying to learn, how long the COVID-19 vaccines protect people. Again, it's an ongoing process. What we know for sure at this time that it works for at least 6 months. And this is coming from the people who participated into the trials before the vaccine came. So we know it's for 6 months. It could be 9 months, it could be 12 months, it could be lifelong. We don't know, but at least 6 months. Now, if it does not last long enough, we might need to get the booster shot. Now, again, the other thing we try to learn, how many people need to be vaccinated till we say we have a population immunity. We don't know that yet. Some people say 70%, some people say 80%. What is important, at least in my perspective, is it's not uniform. Meaning by we need to go region by region. One region might be fully vaccinated, other region may be only 20% vaccinated. So they cannot be treated equally. We need to realize that we need to look at our own region to see how well we are immunized. It's important for the whole country to be immunized, but when we start looking into the population immunity, we start looking into our own regional population immunity and immunization. We are also trying to learn how effective the vaccines are against the new variants of the COVID-19, for example, Delta plus. And so far, it seems like the mRNA, at least mRNA vaccines have been protective against the Delta and Delta plus variants. There could be more variants, maybe we'll find something new. And if there is a case where the new variants are not covered by the vaccines, then we may have to look into getting other newer vaccine or maybe a booster shot. Now, what can we do to prevent the third wave? And when I say we, that means we as the healthcare providers in this meeting today, along with the help of the government, vaccinate everyone who is eligible to receive vaccine as soon as possible. I'll also encourage and request there should be a robust and expedited testing on the younger kids for the vaccine to see if it is safe for them and if it is effective for them. As you might know, in the United States, age 12 and above, people are eligible to get the vaccination, and there are ongoing testing right now as we speak, both with the Moderna and the Pfizer and other vaccinations. And if that test comes back to be positive, meaning by safe and effective, there is a possibility by September or October of this year, kids as young as 6 months of age may be vaccinated. Again, that needs to be seen. We don't know. That's the ongoing testing right now. Other thing, what we can do as a healthcare providers, and I do the same thing, discuss vaccination with every patient who comes to us. Doesn't matter. They're coming for lung problem or they're cervical problem, or they're coming for a general health exam, eye exam, doesn't matter. Ask a question, have you received the vaccination? And if they have not, we need to not push them, because we push them, they feel threatened and they may not get the vaccine. But ask what the concerns are. And I have been doing that. I have noticed there are a lot of myths that the patients come up with. And after talking with them, because they trust me, they have been seeing me for a few years, I have been able to convince a good majority of them to get the vaccine. So please talk with your patients. No matter, just one question: have you received the vaccine? If not, can I help you to answer your concerns? So please try to convince them if they have a concern that could be a myth actually. In the meantime, though, we should keep taking precautions such as wearing masks, maintaining social distancing and hand washing till the number of new infection has been consistently low. Dr. Bharti Kashyap had kind of told me about this, and Dr. Arun Kumar Singh has also mentioned today that the third wave of COVID-19, if it does come, it may affect upwards of 700,000 children in Jharkhand. That's a lot of kids. Now, Many of the children may experience only mild symptoms, but some may develop severe symptoms requiring admission to PICU or Pediatric Intensive Care Unit. Now, some children, irrespective of the severity of symptoms, meaning by at the time of infection, they may have had mild infection, may develop MIS-C in 4 to 6 weeks after they have been infected. And that's the important topic today that will be discussed very well by the two speakers after my talk today. So in general, what is the MIS-C? The multi-inflammatory, it is multi-system inflammatory syndrome in children, or MISC, also known as pediatric multi-system inflammatory syndrome, temporally related to SARS-CoV-2. It is a potentially serious illness and that appears to be a delayed post-infectious complications of COVID-19 infection. It can have a varied symptom that can affect several organs. Excuse me for a second. Okay. Yes, I'm having trouble seeing my screen here. So it may affect many organs and systems in the body. Many children have symptoms resembling toxic shock syndrome or Kawasaki disease, in which the coronary arteries may become enlarged or form aneurysms. Also common are heart inflammation, impaired heart function, low blood pressure, rash, red eyes, and gastrointestinal symptoms. These symptoms can occur in different combinations and will be expertly discussed later in this webinar today. In general, the common symptoms would be fever that lasts more than 24 hours, vomiting, diarrhea, pain in the stomach, skin rash, feeling unusually tired, fast heartbeat, rapid breathing, red eyes, redness or swelling of the lips and tongue, redness or swelling of the hands or feet, headaches, dizziness, lightheadedness, and enlarged lymph nodes. More importantly, there are some warning signs that all the healthcare providers should be aware of, because these are the patients either should be taken care of right away or should be transferred to the place that can be taken care of. And these would include severe stomach pain, difficulty breathing, pale gray or blue colored skin, lips or nail beds, depending on their skin tone, new confusion, inability to wake up or stay awake. While most of the children's hospital in the United States and other medical facilities are still collecting data on MIS-C, it seems so far to be not very common, thankfully. Most children recover to an excellent state of health with careful observation and treatment. Children with MIS-C may need to be hospitalized, but only a few percentage have passed away. So how do we prepare for the third wave of MIS-C? And I was so proud to listen to Honorable Health Secretary Dr. Arun Kumar Singh, that how well prepared the Jharkhand has been, and everything which I was going to mention is being done. So basically, establishing multiple PICUs in different regions, which they have, as Dr. Arun Kumar Singh mentioned, that it has been already been done. My suggestion would have been to assign each geographical area to a PICU, so that with a backup PICU in case the first PICU does not have beds available. So this way, each region knows if I have a patient to transfer, where to call. So there's a relationship between a geographical region and a PICU. There should be secure and prompt communication between the referring centers and providers with the PICU team. They should have been already talked to each other, know each other, have a relationship with each other, and have a trust with each other. Educate the healthcare providers, even in smaller communities, to recognize the warning signs so they can promptly call the PICU to transfer the patient. And this relationship between the small centers, healthcare providers, and PICU is very important, because that's the conversation they need to have. Okay, this is what's happening to the patient, explain, and be prepared to answer the questions. This way, the PICU team can decide whether the patient needs to be transferred or the patient can be taken care of where they are. This way, the PICU can be utilized appropriately. There should be, as Dr. Arun Kumar Singh said, there's already 24 ambulances being designated for the transfer, which is very important. If PICU team decide patient to be transferred, then the transfer should be happening right away, no delays, meaning within minutes. And that's the right thing to do. Is if a healthcare provider calls PICU said patient needs to be coming here, transportation should be like immediately available with no delay. Again, as the PICU team should be prepared. I was just learned from Dr. Arun Kumar Singh that they have been preparing the general practitioner to do the pediatric work as well, which is very important. They should be educated with management of MIS-C, manage the have the protocol and follow the protocol. And again, as the next two speakers will be talking more about the protocol, it's very important. And make appropriate laboratory tests, equipments, and drugs available. And I think they'll be also elaborated by the next two speakers. So with that, I think I will stop and take any questions if you have.
Thank you, Dr. Ravi. Your part was basically the suggestions. And now you very well know after the address of Honorable Arun Kumar Singh that the government has prepared a lot. There are a lot of ambulances, new PICU coming up at Pramandaliya Hospital as well as district hospitals. But the need is to connect, and there may be a common patho lab connecting the district PICU to the bigger PICU, because one common very advanced patho lab can justify the need of all those very fast blood reports. So any question from Dr. Diwakar, TMH head, Pediatrics? So over to Dr. Yonja Bullet. Dr. Yonja, are you there?
Yes, I'm here. I'll be sharing my screen. Can you hear me well?
Okay, just wait a moment. Dr. Yonja Bullet is Professor of Pediatrics, Department of Pediatrics, David Zephyr School of Medicine, University of California and Los Angeles. Welcome, Yonja.
Thank you very much. Can you hear me well?
Yes, yes. Very much.
Very good. Oh, very good. Thank you very much for inviting me. I'm honored to participate in this symposium. And today I'll be talking about the ICU management of the MISC. 1 second, please. Screen göremiyorum. Okay, 1 second. I'm sorry. I'll just make sure that I will put this in. Okay, thank you. Today, my objectives are which children with COVID will be requiring hospitalization, how do we define severity, and what are the presenting symptoms of COVID-19 in children, management of the hospitalized patients, what is necessary manpower, supplies, medical management, and what is MISC. Dr. Ravi Kashyap already talked about it, but I will just open up a little bit more. And what are the current treatment modalities for MISC, and what are the presenting symptoms? It is important to understand the assessment of the severity because not all children will be admitted. When we say that in children, COVID usually are mild, in rare cases, children will be admitted. Only maybe 10% of the population had COVID, pediatric population had COVID, and in that, maybe 1-2% got admitted. But when the numbers are so much, the 700,000 children could be affected, it will be important to understand the severity. So when we say mild and moderate disease, there is no increased oxygen requirement. When we say severe disease, this is new requirement for oxygen or increased requirement from the baseline oxygen needs. And when we say critical disease, this is new or increased need for some sort of invasive or non-invasive mechanical ventilation, sepsis, multi-organ failure, or rapid worsening of the clinical status. So why this is important? Because this is how we will decide that who will require hospitalization. If the patients have severe disease, meaning that requiring oxygen, they will require hospitalization. Of course, they are critical disease with mechanical ventilation, sepsis, multi-organ failure, they will require hospitalization. But there are children that not severe, but may need hospitalization and monitoring. Who are these children? If they have underlying conditions, such as immunocompromised children, febrile children less than 30 days old with a COVID illness, genetic or neurological or metabolic disorders, congenital heart disease. Of course, we know that obesity, diabetes, asthma, lung disease, and sickle cell are risk factors for these patients. So what are the signs of symptoms of COVID? How do COVID patients present? In adults, they are mostly respiratory symptoms, but in children, they could present with a fever, most of them, cough, shortness of breath. That's 63% of the symptoms. They may come with myalgias, headaches, diarrhea, abdominal pain. Loss of smell is not as much as in the adults, like only 8%. They will not be feeding well. Or they may come in the very severe condition with the respiratory failure, myocarditis, shock, acute renal failure, a multi-organ failure, an intussusception or an appendicitis, an acute abdomen, or a diabetic ketoacidosis. The diabetes cases are also increasing. And by the time that we see these children, there are a lot of diabetic ketoacidosis. So what are the laboratory tests that we order? What are we looking? Simply a complete blood count. There may be some lymphopenia or lymphocytosis. Or we are looking for a complete metabolic panel, meaning just the electrolytes and the liver enzymes. Because if the liver enzymes are elevated and lymphopenia, that may be a poorer prognosis. It will be important to have blood culture and urine culture. Remember, this is not every children. These are the children that's severe or they have underlying conditions required hospitalization. And then CRP, ESR, procalcitonin, any one of them to check if there is inflammation. Coagulation test may helpful too. Chest X-ray is not necessary for every single children, but if they have any respiratory distress or oxygen requirement, it may be beneficial. What we see is unilateral or bilateral infiltrates. And if there is severe, you could order a CT. And in the CT, this ground glass opacity is on CT, and the consolidation with this halo-looking, that halo sign, this is how the halo sign will look like in the CT scan. In the management of the hospitalized patients, what do we need? Pediatric ICU care or an intermediate care? What do we need in those hospital beds? Monitors and the ventilator connection and oxygen connection. Equipped to monitor a heart rate, blood pressure, temperature, and oxygen saturation. And the manpower is also important. Pediatric nursing, of course, it may not be, of course, 1 to 4, but nursing for ICU patients are important, pediatric patients. A pediatric ICU physician, even if there's a centralized pediatric ICU physician, could help the others. Doesn't have to be for even a 20, 30 bed pediatric ICU. And pediatric anesthesiologist or an adult anesthesiologist, important to manage the airway because pediatric airways they are not just small adults. It's quite complex sometimes, and you want the most experienced person intubating these children. A centralized pediatric pharmacist is so essential because of the drug doses, that if you are giving that, which dose, how to give it, if you don't have that fund. If there's a centralized pediatric pharmacist, it will be very important to help everyone about how much fluid to give, what kind of fluids to be given, and if there is available respiratory therapists. What are the equipments, the supplies? Monitoring devices, a pulse oximetry, oxygen supplies. But having the oxygen is not enough. Having the delivery system, children will require smaller tubes, smaller cannulas, smaller prongs for their nose. So the pediatric sizes is important. So even if you have oxygen, you may not be able to deliver to children. The high flow nasal cannula and simple masks, the children's size simple masks and non-breather masks necessary, again, for the ventilators. So how do we treat the oxygen, like treatment recommendation for oxygen therapy and non-invasive mechanical support? First, the children, initially, we thought that the children with the COVID has to be treated differently. There was a lot of difference in opinions that initially about how to manage these children. Don't use high flow, don't intubate early. We find out after a year later that we should just continue what we are doing before, giving a good old critical care, so that if the child is requiring oxygen, if their saturation in room air is less than 94, 92, just a regular nasal cannula oxygen. If this is not enough, then you could add a reservoir bag. And if this is not enough, then you could just escalate to a high flow nasal cannula oxygen. If these children are wheezing and if you need to use a nebulizer because of contamination on everywhere, it's important to maybe use a meter dose inhaler, those puff ones, instead of the aerosolized ones. And then if the child has failed the high flow nasal cannula oxygen, then a BiPAP machine could be used before ventilator. If you decide the ventilator, it is the most important to be bagged and intubated with the most senior person, and should be intubated with a cuffed endotracheal tube, meaning that so that the particles will not spread everywhere. And here I'm showing a picture of the viral filter. So this viral filter is also important to connect, so that will prevent all the COVID particles to spread around while you are bagging the child. And ventilator management is similar, but it's really important that bagging, masking, and intubation could be done with a skilled person and children. Otherwise, the other people would also get infected. And staff should use contact and droplet precautions and N95 mask if you are using aerosol generation with a high flow, BiPAP, or intubation. If the child is in shock, since the COVID is a viral sepsis and a septic shock due to a viral sepsis, surviving sepsis guidelines continue. I put the QR code for the survival sepsis guidelines, and in this one gives you the blood pressures that expected. So if the patient is in shock, obtaining an IV and continuing what's necessary with the fluid resuscitation. And these are the blood pressures for the age groups that you could pull it from the with the QR code. And if there is no blood pressure cuff, and if you need to see if this patient is in shock or not, of course, you could use the World Health Organization criteria of cold extremities, prolonged capillary refill greater than 2 seconds, and a weak and fast pulses. If the patient is in shock, and important to be not to be so aggressive with the fluid resuscitation. If there is hypoperfusion but the normal blood pressure, if the blood pressure is okay, we should not continue giving fluids because they may not be able to intubate or ventilate this patient if they get fluid overloaded. So if the patient is in shock and has low blood pressure according to these criteria, then you could give the 10 to 20 cc per kilo fluid boluses and continue with another 10, 20, as long as the patient is requiring an appropriate pressors. Management of children with the hospitalized children. Remdesivir is an antiviral drug that benefits are being shown in the clinical trials with adults. There is currently, it's only used for the emergency use authorization for children less than 12 years old. If the children are above 12 years old, and if they are requiring oxygen, it could be used as an antiviral agent. And again, the steroids showed improved outcome in adult studies in the recovery trial, but effectiveness of steroids in children is not sufficiently evaluated. We have to be careful when we are exploring data from the adult studies. So in these adult studies, the decadron may be beneficial for some children that if you are requiring not just 1 or 2 liters of oxygen, but if they are requiring high flow of nasal cannula oxygen or mechanical ventilation, you may consider dexamethasone decadron. And if the decadron is not available, you could consider prednisolone or methylprednisolone. And the co-infections could happen with the viruses, other viruses, RSV, influenza, and rhinovirus. Right now, we are seeing quite a bit of RSV, influenza, rhinovirus here in the United States. Also, secondary bacterial infections are important, fungal infections, aspergillosis, and mycormycosis. Mycormycosis, it's been mentioned that there was, I guess, like 152 patients with that. This could happen. Usually we see it in immunocompromised patients. It is important. What does Rhizopus mucor loves? It loves glucose and it loves iron. So it's important to have a good glucose control and avoiding steroids and maybe avoiding giving iron supplements if the patient is on some sort of vitamin supplement of iron supplementation. And of course, if necessary, antifungals. So starting empiric antibiotics will be useful. MISC. So we talked about it. Dr. Ravi Kashyap talked about the MISC, what it is, multi-system inflammatory syndrome. These children developed failure, multi-organ failure or shock 4-6 weeks later, but 50% of them had asymptomatic COVID. So they will not come and tell you that they had COVID. So 50%, they don't even know that they had COVID, but they come in 4 weeks, 6 weeks later with a shock picture. There are multiple definitions, but this is the two that we are accepting, the CDC and WHO definition, the age of 21 or less, fever, multi-system involvement, meaning that severe illness and 2 organ involvement, or any of these 2 of the organ involvement, laboratory evidence of inflammation in both definitions, and either increase CRP, ESR, procalcitonin. But regardless of the CDC versus WHO, that both of them are requiring that no other explanation or no obvious microbial cause. And recent infection of exposure of either a positive PCR, positive serology, a family person with the COVID, likely exposure in 4 weeks has to be in the definition. When we look at the COVID patients and the MISC patients, here in the left side, you are seeing a graph of 7-day moving average of the COVID patients in this 250,000 here in January and May, it just went down. And this is the MISC patients. You are seeing that the numbers are not that much. This is from CDC that I pulled. So that when the COVID numbers were 250,000, your MISC numbers were just 25. So it is a rare disease. However, it is a scary disease because if you miss it, that there could be a shock and multi-system involvement. And this is the age group of the disease. It's a little bit older children rather than the younger children. As Dr. Kashyap talked about it, that the symptoms could be anything and everything. So this disease fools us. It could come with, I have admitted patients that who are admitted as an appendicitis or a seizure disorder or other reasons. So they can come with fever and cardiovascular involvement, with shock, and abdominal pain, quite a bit of a, GI symptoms we are seeing with diarrhea. They could have rash. They may have neurological symptoms. And this week just published another one that retropharyngeal edema, so they may come with a lot of throat pain or a sore throat. And these are different. These children, MISC children, are different than the Kawasaki disease. What are the differences? It's more like a toxic shock syndrome than the Kawasaki shock or Kawasaki disease. When you look at that, the age is more like 9-10 rather than 2 in Kawasaki disease. They have severe gastrointestinal symptoms. In the Kawasaki, we don't see that. Myocardial dysfunction, they come with shock. Usually Kawasaki disease doesn't come with a shock. Usually toxic shock or the Kawasaki shock syndrome come with it. And the coronary artery dilatation is transient in MISC and toxic shock, but it is, stays more for it's longer in the Kawasaki disease. They have D-dimers and high troponin levels, which is not the case for the Kawasaki. Lymphopenia and thrombocytopenia, this is simple. If you just get a simple CBC, you will see that the Kawasaki children usually will have higher platelet count, but in the MISC, they have lymphopenia and thrombocytopenia. Well, the good news is that they all respond to the same treatment of IVIG and steroids. So this is diagnostic pathway for MISC. We use here at UCLA, and a lot of the institutions use the American College of Rheumatology, which is wonderfully spelled every step for us. And I can put the QR code here. And if you want to reach me through my email, I'll be happy to, direct you to resources. So if a patient is admitted with all the criteria which suggested, that with the fever, with any of these two, and has some sort of a epidemiological link to the SARS, then we look at the next step. Does the patient is in shock or not in shock? If the patient is not in shock, you order tier 1 lab work. If the patient is in shock, then you order both tier 1 and tier 2 lab work. What are these lab works? So tier 1 lab work is your simple complete blood count, which is your white blood cell count, hemoglobin, hematocrit, and a complete metabolic panel, your electrolytes, and inflammation, either CRP or ESR, and your COVID test. If any one of these results come back with an elevated CRP, severely elevated ESR, or severe lymphopenia, thrombocytopenia, hyponatremia, hypoalbuminemia, then you will say, wait a minute, maybe I should order further tests. And these are the tier 2 labs. That will be important for the centralized lab because these results may not come right away, such as brain natriuretic peptide and troponin that we depend quite a bit. Ferritin could be like an inflammatory reactant could be found. And then here, the rest of it you are seeing. And if you go to the guidelines, it will be all spelled in that one. If a patient is having this, it's very important to get an EKG and a cardiac echogram. And if there's shock, ordering both tier 1 and tier 2 lab work. And how will we treat these patients? Again, we follow the American College of Rheumatology guidelines, and which is the American Academy of Pediatrics recommends. And then you can pull it up from here. If the patient is in shock or not, that's the first question. Is the patient has an LV dysfunction or coronary artery disease, which Dr. Pooja Kashyap will talk about, an increased troponin or arrhythmia? If patient has any of these things, yes or no. If the patient doesn't have any of those things, you could give a first-line treatment of IVIG, immunoglobulin, 2 grams per kilo, and over 8 to 12 hours, maximum is 100 grams. And if you think that the child will be food overloaded for some reason, then you could give that in a 2 divided doses. If the patient has a refractory disease, then you could consider what is the definition of a refractory disease. It is persistent fevers, increased brain natriuretic peptide, ferritin, D-dimers, unexplained tachycardia. Child is still having quite a bit of inflammation. Then you could consider a low dose of methylprednisolone, 1 to 2 milligrams per kilo, or anakinra if is available, an IL-1 inhibitor. Let's say that if our patient is in severe shock and has any one of these, then the first-line treatment will be a combination of IVIG and methylprednisolone. Of course, the fluid resuscitation, vasopressors, and antibiotics. There are studies that could use both of them. Using both of them, that's beneficial. And there are studies showing that if the IVIG is not available, that using high-dose steroids could be acceptable. There are 2 studies came out in New England Journal of Medicine last week that one of them was saying that the Boston-based group, the Overcoming COVID, in that group, IVIG plus prednisolone did a better outcome, showed a better outcome than just the steroid alone. But the international study, the BAT study, showing that the methylprednisolone high doses as good of a response, or there was no difference in the treatment. Again, or you could use anakinra if it's available. If any one of those are used, the children should be weaned from them on 3 weeks. And how about antithrombotic treatment in this? Again, same guidelines helps us. All patients should be started on a low dose aspirin for thromboplastis, unless if the platelet count is low, if there is bleeding or bleeding diathesis, that should not be done. Dose is 3 to 5 milligrams per kilo and maximum is 81 milligrams. Again, patient with MIS-C or coronary artery aneurysms should be also on low dose aspirin. So who will require both the low molecular heparin and the low dose aspirin? Which patients are these that will require both of them, that with the MIS-C diagnosis? Those are the ones that who will have current or prior VTE, venothrombotic events, or severe LV dysfunction defined as less than 35% ejection fraction, elevated D-dimers, greater than 10 times the upper limit of the lab, or very large coronary aneurysms, Z-score greater than 10, will be on low molecular heparin and low dose aspirin. If none of these are happening, but the patient is requiring ICU for whatever reason, then the prophylactic dose of anticoagulation therapy is whatever the protocol that could be used. And antibiotics. MIS-C can present with the signs and symptoms that would be like a shock or a toxic shock. So it is important to start a broad spectrum antibiotic right away. You could choose a third generation cephalosporin, you could choose a Zosyn or Peptazole, and then if the cultures are negative, you could stop them. For the summary, the supportive care is very important. Empiric antibiotic therapy initially, limited role of antivirals. Remdesivir makes it maybe 5 days versus 15 days in adult population. Immunomodulating treatments, if there's a severe disease, shock, vasopressor use, and aneurysms, then IVIG plus steroids or IL-1 inhibitors like the shared with the protocol, or less severe manifestations could be managed with IVIG alone. If there is for prevention of the thrombotic events, low dose aspirin will be useful, or the anticoagulation as I shared before. The follow-up of the patients, Dr. Pooja Kashyap will go over this, but pediatric cardiology should follow the patient. And if there's a normal function, just 2 weeks later, an echocardiography. And then if there's dilatation of aneurysms, maybe in every 2 or 3 days, but I will let Dr. Pooja Kashyap talk about that. Important that limiting the physical activity for a period of time, 3 to 6 months after the severe hospitalization with MIS-C. And if the children had cardiac involvement, should be followed up with pediatric cardiologists and pediatric rheumatologists if they are on any of the biologic agents afterwards. Thank you very much.
Unmute me. Hello, Dr. Diva. Thank you so much, Dr. Yonja. We are really thankful that on 4th July, which is a national holiday, you all guys have taken time out in the midnight. So thank you once again. So there is our discussant is TMH Jamshedpur Pediatrics Head, Dr. Divakar. So Dr. Divakar, are you there?
Yeah, thank you, Dr. Kashyap, and thank you, Dr. Yonkabolet. And that's an excellent presentation, and I thoroughly enjoyed it. I have a few questions. Probably you did not cover because of the lack of time. How do you feed on a HFNC? So do you reduce the flow during feeding, or you continue the same flow? And second question is, how do you wean them? So once you wean them, they have to bring down the flow directly to the low flow, or you wean the flow as well? Thank you.
Okay. Thank you for the question. For the high flow, the maximum high flow that we will use is 2 cc per kilo for the high flow rate. Let's say it's a 10 kilo patient that I will not use more than 20 on that patient. We will start slow. So the minimum amount of flow that is necessary that I would use, especially in a COVID patient, that if the patient is, let's say, 6 liters and at 30%, and if this is a little desaturated, maybe it is better to just go up on the oxygen a little bit. Again, if the patient is atelectasis and not taking deep breath, or you're requiring or it is a work of breathing, because what you're trying to do with the high flow is prevent high work of breathing. So then you will go up on the flow, not in the oxygen. Does this answer the question or?
Thank you. And how do you wean them? So you reduce you directly go to low flow, or you wean flow and then go to low flow?
So depending on the patient, if the patient, I try to wean the flow first. If I bring the oxygen level to, let's say, 30%, if the patient is 100%, if the patient is 60, 50%, I will not wean the flow. I'll bring the oxygen level to 30%, let's say first, then slowly come down on the flow. When you're coming down on the flow, if the patient becomes tachypnic, then your patient is telling you that it needs that little bit of the peak that what you're generating. Then I will be in the flow. When the flow hits the 4 liters, I'll just switch to a regular cannula oxygen.
Thank you. And when do you consider it's a failure? So it's a 5 to cut off 60%, or you go beyond 60% on the high flow as well? once you have reached the maximum? Yeah.
Multiple things. It is not just the amount of the FiO2. If a patient isn't requiring, of course, 100% high flow and is, let's say, a 10-kilo patient, so 20 liters, that is quite a bit. I will be preparing for an intubation on that patient because there is no other other avenue. There is nothing left. And tachypnea is also important too. So it isn't just one thing. The patient could be on 40 liters and it could be on 20 liters and 40%, but if the respiratory rate of the same child, 10-kilo child, has 80 of respiratory rate, then that is a failure. So the combination of the respiratory rate, combination also of if the saturation is going to the 92 in FiO2 greater than, let's say, 50%, and is requiring more and more flow and tugging, flaring, nasal flaring, tugging, using all the extra accessory muscles, so all of them combination.
So do you go beyond 60%?
Yes, we go, but sometimes we go beyond 60%. But if I'm going on 60% in a patient, let's say the patient's on 100% FiO2 and 10 liters flow or 20 liters flow, you could do that. Is it because you just want to give somebody a Lasix diuretics to just you just need a couple of hours to make things better? Yes, you could use it. Yes, you could use it. And if you don't have a ventilator, you could use it long term. Of course, you could use it.
Okay, thank you. Dr. Kashyap, do you have time for more discussion or?
Yes, I do.
What I think that please stay connected. Dr. You can ask, you have one more question to Dr. Yonja?
Yes, I do.
Yes, you do. You are from Jamshedpur and a lot of ministers area. Please continue. Dr. Divakar is there from the TMH head pediatrician.
So, Dr. regarding the feeding and the oral feeding, so do you reduce flow during feeding, or you are happy with the 2 ml per kg flow and oral feeding if possible, if respiratory test is not there?
If you say that in the old days, we said that if you're on high flow, we are not feeding, or if you're on a BiPAP, we are not feeding. But now that lately in the last year or so, that the research is showing that it does not make a difference. So what makes a difference is the child is throwing up. When you're giving a high flow and feeding, don't feed. If the child is not throwing up, continue feeding. If the child is on 100% and a 20 liter, you're just going to intubate this child, of course, needs to be an MPO, don't feed it. So it is all about the child, what the child's needs. If things are getting worse, I wouldn't feed. But there is no rule that I'm on high flow, I'm not going to feed. Yes, you can feed the children on high flow.
Thank you. Thanks a lot.
Of course.
Because we need you as a discussant for the third session also. So thanks, Dr. Yonja, for staying awake till midnight.
Thank you
so much. So I request you to stay connected till our Honorable Minister's speech. So he would be thanking you all. So now the third session starts. It is by Dr. Pooja Kashyap. She is the pediatric cardiologist, Director of Adult Congenital Program and Assistant Professor, University of Texas, USA. So topic is cardiologist point of view for COVID-19, cardiac involvement in COVID-19 and MIS-C, role of cardiac echocardiography test, how does it affect management, when do we start anticoagulation and how long we continue. Cardiology follow-up after severe COVID-19 and MIS-C, and the time duration is 15 minutes. Okay, over to Dr. Pooja. Please stay connected.
Yep. Thank you. Thank you. Very good morning to everybody. And namaste to Honorable Health Minister Ji, Dr. Banna Gupta. And thank you, Dr. Bharti Kashyap, for arranging this. I'm very pleased to hear all during introduction that how motivated and committed everybody is there at Jharkhand and in India to fight this COVID. And it is very encouraging. And I'm really thankful to all of you there who are actually the front line and helping all the patients there. So thank you. Now, Dr. Ravi Kashyap and Dr. Bullet, thank you. You have taken the brunt of explaining everything about COVID-19 and MISC, which makes my job really simple because I only deal with a little portion there, which is the cardiac. So it should be, it is small, but it is very, very, very important. So without wasting any time, let's, are you guys able to see my slides? Yeah, okay.
Yes.
So objectives, the evolution of COVID-19 and the MISC really interests me, the timeline. So I'll just briefly go over that. I'm sure all of you know that. And the cardiac manifestations in COVID-19. What is the major difference between adults and pediatrics? That's, I think, the key there. And just to recognize that the heart is now involved, and let's manage that and then support the heart, and let's get the patient out of the hospital and prevent the mortality. Essentially, that is the gist of my talk. And what are the key points and the buzz things that you're looking for while you're managing the patient. So it was late 2019, somewhere in December, when in China, Wuhan, China, as we all know, that there was severe acute respiratory syndrome that started caused by coronavirus 2, and then the disease started to be called as COVID-19. By March 11th of 2020, it was declared as pandemic. April 27, 2020, that is almost 5 months after this, UK started seeing this hyperinflammation kind of syndrome, Kawasaki-like disease in kids, and they started to look into it more. And by May 1st, they defined it as pediatric inflammatory multisystem syndrome, which was temporarily associated with SARS-CoV infection. Not too long after that, in May, it came to US, and the New York City Department of Health started now getting the, more aware and started looking into these cases. By May 2020 late, the CDC had given it a name. It is MISC, right? And it's been there, but COVID-19 has been there, and there has been first wave, second wave, and now we are preparing for the third wave. After the second wave, I would say there were a little more awareness about MISC, so we knew a little more cases, the way I see it. The first wave, the lag for the onset of MISC kind of did not reflect upon the number of cases. So coming to the cardiac manifestation and COVID-19 in adults, you see it right away during the acute infection. The heart in some patients is involved. There is myocardial dysfunction, kind of MI picture, and cardiogenic shock and effusion. In pediatric patients, like the previous two speakers mentioned, the initial COVID-19 infection is mild, and we do not see cardiac involvement in the acute phase. So much so that when after 4 to 6 weeks, if the child presents, they don't even know sometimes that we have COVID. But then we see all the similar features that we have seen in adults to a different degree: myocardial dysfunction, myocarditis, and of course, coronary artery involvement, which confuses us about Kawasaki. I still remember it was April, I think it was somewhere around April or May, that we suddenly started seeing more Kawasaki disease in the ICU, and we started getting more consults. And we were like, what is going on here? And this was right about the time when all of this was coming up. So yes, Kawasaki disease manifestation kind of confuses with the COVID-19 MISC. The key thing is that COVID-19 initial infection would be mild, and the MISC would be 4 to 6 weeks after the peak incidence of COVID-19 infection in a set geographic area. So if there has been an outbreak, an increased number of cases of COVID-19 in, say, one city, one state, you would see, or you should anticipate or prevent and prepare for seeing cluster of a few of these MIS cases 4 to 6 weeks later in that geographic area. That is how the trend has been. And it is all secondary to the post-infectious immune-mediated complication. So the rapid PCR test that you would do would most likely be negative, but the serology may be positive in 75 to 90%. Now, there has been some cases in which none of these tests have been positive. Again, not going into the details of the symptoms, but the key things are, the way I put it in my mind is that if there has been fever and Kawasaki-like symptoms, and definitely GI symptoms, gastrointestinal, where there is nausea, abdominal pain, get alerted, get BNP and troponin and echocardiogram, and you would know what is going on with the child. So like I said, the cardiac manifestation, essentially what SARS does is it essentially attacks the multi-system. It attacks the cardiac organ, the gastrointestinal organ, the lungs, the renal, and the skin. It's all part of that immune-mediated complex reaction. And that what causes this endothelial injury and hypercoagulability. That is what we see. So this is a simple slide, a table that I took from how to approach and when to consider pediatric cardiology referral for COVID-19 patients. This was published in November of 2020 in the Pediatric Cardiology Journal here. It, I think, puts everything, it's a good gist of things where initially you would see the symptoms listed and the test, followed by the red flags where if there has been fever for more than 3 days, clinical features of Kawasaki, shock, heart failure, then what all tests you should do. Tier 1 and Tier 2, like Dr. Bullitt had mentioned, I am biased because I'm cardiologist. I would say if you're getting CRP and ESR, just get the BNP and troponin if you are suspecting, you know. And if those are elevated, yes, then you need to start thinking about how to get this patient to a place where I can get a baseline EKG, where I can get an echocardiogram if needed, because sometimes the initial presentation is not shock. It is not obvious. It could be just a mild dysfunction, but the kid would still need support. So, so MISC and Kawasaki, like I said, it kind of confused us. Our, cardiology colleagues were like, what is this? And I think I just listed here the key differences. And I just want you to know that if the age of the child is above 8, it is kind of less likely that it is going to be Kawasaki. That's just my kind of cheat sheet. So age, onset. Usually 5 days of illness is what you see with Kawasaki. Here we see about 3 to 4 days. Shock is very rare in Kawasaki. So 50% of the presenting cases of MISC and COVID in shock definitely is COVID, no matter what the test shows. Negative COVID, it doesn't matter. Treat the shock, think about it. GI symptoms is definitely more common in MISC. So not taking too much time here. Again, I listed BNP and troponin because I'm a big fan of those 2 labs. They can save lives. So besides the BNP and troponin, CRP, fibrinogen, ferritin, and D-dimer. These are the top labs that help us as cardiologists. Of course, this is just in continuation of Dr. Bullitt's talk. So that is all the major key points. This is just the cardiac from the cardiologist standpoint. So now what do we do? We have established the kids' BNP is high, troponin is high, CRP is high, has Kawasaki symptoms. Now the kid, I am just going to assume, is in a tertiary hospital where there is facility to get echocardiogram, EKG. Okay, so now the key thing is get focused echocardiogram because you really don't want to expose the tech or the physician who's doing the echo to get into the details and getting all the images and the protocol, which ideally, it takes about 30 to 40 minutes to get a full echocardiogram. I would not suggest that you do that, and neither does the American Society of Echocardiography does. They came up with this whole list of protocols and situations where the echocardiogram was really so mandatory to put that staff to that exposure to COVID, if that makes sense. So essentially what you're looking for is left and right ventricular function, the pericardium, if there has been pericardial effusion or not, any valvular dysfunction, which means mitral valve regurg, coronary arteries, and in kids, one of the other differences between adults and kids is that you put the probe on the child and you can see coronary arteries clear. In adults, we don't give those images with the echo, so it's hard. So this is the advantage. And so echocardiogram views, just get 2 views. If there is a technician there who does the echocardiogram, train them to just get the apical 4-chamber and short axis, and then move on to subcostal views if at all needed. But and if you have any questions about this in terms of the protocols, I'll be happy to share with you guys. And then have availability of the pediatric echocardiogram probes, because generally for adults, we use probe size 2.5 to 5, but for pediatric, you need a higher frequency probe because it needs lesser penetration. So just having those probes with you will help you. So like I said, the most common that we see is left ventricular dysfunction. And then the second is the coronary artery aneurysm and dilation. I personally have seen in only 2 of the patients, so it's fairly uncommon, more common in Kawasaki. Pericardial effusion, you will see it's very common, and mitral regurgitation also. So these are some views, which essentially the first is showing you the dilation of the right coronary artery. Like I said, the kids give really good images of the coronary arteries. The second one shows the mitral regurg, the little blue flash that is going into the upper chamber, which is the left atrium. And the third picture is pericardial effusion. It is collection of more fluid around the heart, which can affect it hemodynamically and cause lower blood pressure if it is large effusion. And the picture right below it is the myocardial dysfunction, which is also you can get from apical 4 views, just the ejection fraction, which is the key. And the one right next to it is this balloon-looking lower chamber, which is the left ventricle, which is dilated and its function is down. So all of these key 5 images you can get from the 2 views that I mentioned. Now, EKG. EKG is really essential because we have seen in MISC that there are certain arrhythmias, especially in adults now, that arrhythmias do occur and they are associated with high mortality. So having a baseline EKG, placing the patient on a continuous telemetry where we can actually monitor the rhythm would be excellent. Also to keep in mind is sometimes there are electrolyte disturbances like low sodium, low potassium, calcium, and all of that can throw some abnormal ventricular premature beats. We have to be on top of those to correct those. Most commonly, we have also seen sinus node dysfunction and bradycardia, PR prolongation, and the inherited channelopathies, which are essentially a real big major cause of sudden cardiac death in certain kids that have not been recognized. We have seen sometimes it kind of gets unmasked. You come to know that the kid now has prolonged QT. Because of the fever that a child is having, you kind of recognize Brugada pattern. So all of these things, unless you have a baseline EKG and you follow it along, you won't be able to recognize. So it's very helpful. Now, coronary involvement, like I mentioned, it's not as common, but still it is there because it kind of directs our therapy. we do measure the size of the coronary arteries and kind of adjust it to the patient's height and body surface area, which essentially gives us the Z-score, and that decides as to what we are doing with this patient in terms of anticoagulation and the follow-ups and the advanced imaging. So it's kind of very valuable information. So management consideration, again, BNP and troponin, echocardiogram, continuous telemetry, and hemodynamic support, okay? Of course, the key is to determine the level of care first, which has been touched base before, so going forward. So recommended timeline, I think, is the key as to when should you now, you've gotten the initial echocardiogram. It says, let's pick a number. Let's say normal is about 55% and above of the ejection fraction. And let's say the child has ejection fraction of 55%, which is low normal. And otherwise the patient is hemodynamically stable. The blood pressures are great, just has fever and some respiratory symptoms, is on binasal cannula, really not requiring that much support. So you say, okay, let me put this child on an acute care floor. And now what do I do? Number one, always put this kid, I would suggest that have this kid on a continuous telemetry bed so that you can monitor the rhythm. Second, if you are admitting and you have a baseline echo, repeat it in 2 days, unless there has been some change in the clinical status. Just make sure that the inflammation and the immune response has not caused increase in the pericardial effusion, has not resulted in coronary artery dilation, and has not resulted in any decreased function. So kind of if the patient is in the hospital, just repeat the echo in 2 to 3 days. But if the patient directly goes to the ICU because of the hemodynamic instability, then we do recommend to follow echocardiograms daily to almost every alternate day, just till the time the patient has started de-intensifying, means that is requiring less inotropes, has required less respiratory support. If BNP and troponin are trending towards normalization, like their trend is now decreasing and it's reassuring, then yes, you can say, okay, let's get the echo in 2 to 3 days. But till then, just be on a high alert. And part of this is because it is an evolving condition. It's not like the first echo is fine, so everything would be fine. It all depends on the clinical status. So having that facility in the hospital is very essential. Advanced imaging, I'll come to it later. So again, management, just going by the 3 major things that we see in the heart: myocarditis or myocardial injury. First thing, look at the function, labs and echo, and treatment usually is diuretics, just because you have to be a little careful about the fluid balance. If the heart function is not optimal, you cannot really fluid overload the patient. So the patient needs diuretics and heart failure therapy as needed. Now, does the patient need IVIG or not? I would refer to that American rheumatology recommendations as to when to start giving IVIG. But if the patient is on the floor and is otherwise recovering, I don't see the need. We have not really practiced that here. But if the patient is hemodynamically unstable, is in shock, the first thing is, like Dr. Bullitt said, take care of the shock and the sepsis first. Let the labs and the echo speak later and do the cardiac stuff later. You have to manage the patient as a shock patient. And we have seen that it is mostly a vasoplegic shock. So you need like norepi or epi. Now, if the echo and BNP are elevated and echo is showing cardiac dysfunction, our favorite go-to drug is milrinone. But you can add that milrinone only if the blood pressures are holding. And I love that slide where Dr. Bullitt mentioned the normal blood pressure parameters, which is the key. Now, again, for me, who just gets into the key buzz numbers, if it's less than 70 in a pediatric population, systolic is less than 70, you need epi or a norepi to even consider milrinone to add on, because milrinone is an afterload reducer. It will reduce your blood pressure further and it can cause problems. And of course, add diuretics. So be careful with milrinone and that standpoint. If the kidney functions are really bad, milrinone is usually not indicated. So look into all those things before we start milrinone. Now, sometimes you would need mechanical ventilation just to reduce the metabolic demand if the cardiac function is low. So sometimes respiratory support, and I love that question that when do you escalate the care? What Dr. Diwakar said is that when do you start weaning? So it's if the cardiac function is not good, if the blood gases are showing acidosis, lactates are high, you have to kind of say how much weaning of the respiratory support can we actually do at this point. Then comes anticoagulation, which I'm going to go later in the next slide. It depends upon the parameters, which was already touched. IVIG is a great drug that has been extrapolated from the management of Kawasaki, and we do give IVIG to all the patients who are hemodynamically unstable, followed by a diuretic, because again, you don't want to fluid overload this patient. And if the patient is in refractory shock, is requiring more than 2 inotropes, steroids are great. They also help in maintaining the blood pressures and calming down the immune response. As regards the EKG and arrhythmias, electrolytes, the key thing, be on top of it. I think that has helped us a lot. Aggressive fever management, and then just keep them on continuous telemetry. They will probably settle out. Now, there is a website that kind of gives us the list of drugs that can prolong QT. It's the crediblemeds.org. We refer to that a lot just to see if we are giving any antibiotics to a patient that might prolong the QT, just to kind of keep it in the back of your mind. And that's why EKGs help, because the telemetry does not show you the QT interval that well, but the EKG kind of just calculates for you. So QTC is really good to have. Now, anticoagulation therapy is guided by the Kawasaki guidelines. We love aspirin. And then going forward, let's go to the reason why we need to be on anticoagulation. That is who are at risk of developing thrombus, severe LV dysfunction, which is EF of less than 35%, elevated D-dimer, and coronary artery enlargement. Yes, aneurysm, start anticoagulation. So low dose aspirin is our favorite for all sorts of things. For cardiac, cardiologists love aspirin. Just start them on if the platelet count is above 80,000. It's not going to hurt the patient. And then continue it at least till the time the patient is asymptomatic. We sometimes continue it as outpatient depending on how the patient recovered, but it's not indicated at this time. It is indicated in Kawasaki though. Now, the key is, when do you start Lovenox or enoxaparin or warfarin in addition to the aspirin? And that's where the coronary artery aneurysm come into play, or if there is also a documented thrombus. So if the patient has documented thrombus, it has to be continued for at least 3 months after the resolution of thrombus. If the patient had low EF, then at least continue for 2 weeks after discharge. And if the patient had coronary artery aneurysm with the Z-score of 10, it's indefinite. You don't know when you're going to stop unless the aneurysm resolves. We don't know the timeline yet. The good thing is, this is just a reference I put in there just to kind of, it's more so for reassurance that if we recognize this MISC and the cardiac manifestation in comparison with the adults, the last bolded line is that mortality in children with MISC is very uncommon. Number one, it is a rare condition. And number two, if it is managed timely, it's zero mortality. You know, the kids recover really well. This one I put in there as a reference from Journal of American College of Cardiology, just to emphasize that these patients who have had some sort of cardiac involvement during the hospitalization, they do need continued follow-up for echo and EKG, because even though the ejection fraction is normalized before discharge, there has been echo study that has been done, which shows that there's an entity called as diastolic dysfunction, which persists much longer and needs follow-up, which can then result in sudden cardiac events as outpatient. So we need the follow-up after the discharge. I know we are talking about PICU and developing the infrastructure, and I would really request you to consider this, to kind of incorporate that in the plan where the patient who has been admitted in the ICU has had cardiac involvement gets a way to come back into the outpatient clinic to follow up after he has been discharged. So this is cardiac follow-up guidelines, where just as a blanket statement, I'm very comfortable saying that the kid who's had cardiac involvement needs to follow up within 2 weeks of discharge with an echocardiogram and EKG. And this has been extrapolated from the various protocols and the guidelines which have come out for MISC so far. And also to get an EKG, because we have seen that there has been some progressive conduction abnormalities, meaning there has been noted to have some heart blocks, prolonged PR intervals, some sinus node dysfunction in these patients. So we had required a more close monitoring. And of course, for anticoagulation, if the patient is on anticoagulation, we have to follow those patients. So in summary, recognition is the key. Once you have recognized and triaged the patient to the appropriate level of care, which I thank the Health Ministry and Government of India to give so much support and to create the PICUs to train the staff, the physicians, the paramedical staff in preparation for the third wave. It's really commendable. I think triaging those patients to appropriate level of care, this is where the key lies. And a good communication, like Dr. Kashyap mentioned initially, just having that relationship with these centers and just establishing a go-to place would really help. And the time, it would reduce the time that you would take to send this patient to the appropriate level of care. So I think that's great. And availability of a rapid diagnostic test, including the serology test, would be key just to help. Fully staffed and equipped critical care, and the acute care floor would be, a blessing. And you guys are really working hard on that. And echocardiogram and electrocardiogram it's my bread and butter, not because of that, but because it is needed. It is needed in these patients. So having the probes, talking to the techs, okay, the echo technicians, you're comfortable getting these views. Do you have what you need for the echo machines? Do you have a cardiologist out there who can read it? And the electrocardiogram, the way you place the leads on the pediatric population, you're aware how to do that. It's great. 24-hour staff labs so that you can get the labs required, especially the BNP and troponin, back on timely basis to give the patient enough support from medication standpoint. Advanced imaging. So I think I skipped that previously, but advanced imaging like CT and MRI are recommended. And the way I see it is that if you're seeing a coronary artery dilation and it is more than Z-score of 10, you would probably need a cardiac CT just to know if there is a thrombus in it or not, or is it diffuse? Is it going into the extensive branching? Because you can't get that from echo. But you can use cardiac CT used for adults. It is just the protocol that is different. So it is not that difficult to get a cardiac CT because coronary artery involvement in adults is very common. And MRI is not needed right away. They can be sent 3 to 6 months after the MISC or cardiac involvement to a center which specializes in that, just to get an idea about the LV dysfunction if we need to. And of course, having the medications which are commonly used as first line, like norepi, epi, milrinone, IVIG, steroids, Lovenox, aspirin, just having it handy is great, so there is no time lag in having the patient. And of course, outpatient clinic incorporation somehow into all of this would be great. And that's it. Heart is nice and sweet and small. So any questions for me?
Dr. Divakar, please unmute Dr. Divakar.
Thank you, Dr. Kashyap.
Actually, thank you so much, Dr. Pooja. Actually, there are more than 210 doctors who are connected and they are listening. But as there is no question in the question box, we are not unmuting them because it will create a lot of chaos. So Dr. Divakar is there. He is heading the Tata Main Hospital Pediatric Unit in Jamshedpur. So over to Dr. Divakar. You have any question, Dr. Divakar?
And thank you, Dr. Kashyap, for such extensive presentation in a short time. You covered almost everything. What we have seen in our practice that children with a fever and they do not fulfill all the criteria of the MIS-C, but they have the inflammatory marker high. So your experience and how do you manage them? So they might have RAS, but they do not fulfill the two clinical criteria. Sometimes they are RT-PCR COVID positive. So it's very difficult to see that where this inflammation is because of hyperinflammation or because of due to COVID. So your experience and how do you manage them?
So thank you, Dr. Divakar, for such a good question. Like I said, it has been puzzling us a lot here as well. So you're not the only one, trust me. But so Mike, just one information before I answer your question is, do they have only elevation of the inflammatory markers, or do they have inflammatory markers elevated and BNP and troponin elevated?
So BNP we are not doing, we do not have the facility. Troponin, so they have since they do not fulfill the clinical criteria, so we are not going to tier 2 investigation, but they have high CRP or ESR, they have the lymphopenia, and one of the patient was the COVID positive, otherwise the antibody positive. So it was very hard for us. Is it because of the COVID or cardiac function were normal? So we did the echo and cardiac function were normal, and we didn't do the troponin.
Okay. So in this case, I'll be very honest. Our first go-to thing is BNP and troponin. That's our first thing that we go to. And I have seen normal cardiac function. It is not uncommon via echo, no effusion, but troponin of 15. The normal here in our lab is less than 0.05. So, but it was elevated to 15. So it is something which is, I would say, if you have the facility or if you can push the administration to get you that would be great in future. However, if there is a doubt, I would consider them and treat them as likely COVID MIC as well, because there is no change in medical management. If you take them as Kawasaki, right? Let's just say you say it's not COVID, it's Kawasaki. Cardiac function is normal. You're still gonna follow them up. You're still gonna give them aspirin, high dose till the fever resolution is there. And then you're gonna put them on low dose aspirin, right? You're still gonna treat them with IVIG if the fever doesn't resolve, right? So the good thing is the treatment protocol is the same. And you are getting echo, which is reassuring. So I think you're doing all the right thing. The only thing I would change is add troponin and BNP if possible. If not, just follow them in future as outpatient, like they were Kawasaki, and just keep a close eye on them. Does that answer your question?
Yeah, thank you. So probably even if they do not fulfill a clinical criteria and they have the hyperinflammation, you still go to tier 2 investigation, and if found it positive, you treat with IVIG. Is this what I wanted to convey?
If it is elevated troponin and BNP, we do treat with IVIG, especially if it is elevated troponin, because it is, I think I didn't touch base on that, because myocarditis is an entity which we see also, as you know, right? And that is diagnosed purely by troponin I or BNP elevation, and that requires IVIG treatment plus minus in different papers what you follow. But so we do treat with IVIG if troponins are elevated.
Thank you. Dr. Bharti Kashyap, do we have time for any more question, or are you going to wind up? Dr. Kashyap, I have another question. I'm used to measuring ejection fraction on the plex, the longitudinal axis. So how do you do it on the 4-chamber view? Can you do it quickly? That's why you're suggesting?
So ejection fraction, you can measure via 2 ways. Number one is M mode, that you can do either in parasternal long axis or short axis. Now, short axis view, I like it because it also gives you coronary artery information, pericardial effusion information, and LVH. You can see because you just have to kind of sweep and you will get all this information from short axis, and you can get the M mode. So that is what I go by. I don't recommend going to parasternal long axis just because it takes a lot of time. Second, apical view, you can get the EF by doing the Simpsons biplane, either in apical 4 or apical 2. That you can measure after you have acquired the image. So acquire the image on the patient, get a nice apical 4 and an apical 2 view, and then you can, depending on the machine, which mostly every machine has that, is you can post-process and measure the Simpsons biplane and get the ejection fraction, which is very accurate. Does that help?
Yeah, thank you. Thanks a lot. And how do you define severe cardiac dysfunction? Is it an objective criteria on ejection fraction or just eyeballing?
No, it is EF of less than 35%. So less than 35% is severe.
And when you put them the heparin or low molecular heparin, so when do you switch over to warfarin? Because they will go for long-term anticoagulation.
Yes.
And obviously
so
we can't
we
like on the subcutaneous heparin.
Yes, so we can, depending on how, when you want to do it in terms of discharge planning, but you can, so which drug are you using for outpatient? Like, what do you send them on?
So we prefer warfarin because of the logistic. Many of them may not be able to get the subcutaneous low molecular weight heparin.
Sure. So then you would have to monitor the INR, right? So for that purposes, I would say start transitioning them at least 4 to 5 days in advance so that you can get a baseline INR, which should be at least 1.8, if not more. 1.8 to 2 would give you a very reasonable anticoagulation because normal is 1.2. So as far as you're close to 1.8, you can send them home and kind of monitor as outpatient. Does that help?
Any experience with oral anticoagulation, apexaben or something in children? Because our adult colleagues have, because in adults, our colleagues are using oral anticoagulation apexaben on discharge.
Yes, you can use those. You can use absolutely.
So even small children, 5 to 10 years old.
Yes, you can.
So there is a question from Dr. Partha, and Dr. Bullet has already answered that if there is no coronary artery dilation and there is no coronary artery aneurysm, but D dimer is very much raised, So in that case, will you give anticoagulation? Not only aspirin, Dr. Bullet has answered, if D-dimer is raised 5 times more than normal, then yes, anticoagulation plus aspirin. Okay, Dr. Pooja?
That's correct. That's correct. D-dimer, if it's elevated by itself, is a criteria to start anticoagulation.
Yes. So, what is the dose of apexaban? What is the dose of apexaban? Dose bataiye.
So I am going back to the. So we go by the factor 10A level. We maintain that for appropriate anticoagulation. It usually started 1 mg per kg. And then we escalated depending on the blood levels.
Okay, so the question of Dr. Partha is all clear. Dr. Divakar, we asked a lot of questions. So all clear. So now I am going to request our Honorable Health Minister, Government of Jharkhand, to address the gathering. There are more than 210 pediatricians working in the government sector or across Jharkhand who are connected and are listening. Over to you, sir.
आवाज आ रही है मेरी?
Is sir audible? सर की आवाज को ठीक
आवाज आ रही है?
सिर्फ सर का लो.
आवाज आ रही है मेरी? सबसे पहले मैं बहुत बधाई देता हूं कोविड-19 थर्ड वेव इंटरनेशनल PICU और क्रिटिकल केयर ट्रेनिंग सिंपोजियम के सफल आयोजन के लिए मैं सबसे पहले डॉक्टर भारती कश्यप को बहुत बहुत बधाई देता हूं और इस बात से मैं मानसिक रूप से सहमत हूं कि डॉक्टर भारती कश्यप एक ना थकने वाली और ना हारने वाली एक महिला सशक्तिकरण की दिशा को मजबूत करने वाली एक महिला चिकित्सक और समाज सुधारक हैं। इसके लिए मैं उनको बहुत बहुत बधाई देता हूं, बहुत बहुत शुभकामना देता हूं। आज के इस सफल कार्यक्रम के बहुत मजबूत आउटपुट होंगे ऐसी मुझे संभावनाएं हैं और आज के कार्यक्रम में जिस तरीके से हम सारे लोग बहुत गंभीरता पूर्वक हमारे वरीय चिकित्सकों की बात सुन रहे थे, सबसे पहले मैं उन चिकित्सकों को भी बहुत धन्यवाद देता हूं जो आज अमेरिका में रात 2:30 बजे बैठकर हमारी समस्याओं के प्रति गहन चिंतन मनन कर रहे हैं और आज उनका हॉलीडे भी है और छुट्टी के दिन होने के बाद भी उन्होंने रात को इतनी गंभीर विषय में अपने चिकित्सक अनुभव को प्रदान किया है। इसके लिए मैं राज्य सरकार की तरफ से बहुत आभार और धन्यवाद व्यक्त करता हूं। विशेष करके डॉक्टर रवि कश्यप, डॉक्टर योजा बुलेट, डॉक्टर पूजा कश्यप और साथ में जुड़े हमारे सभी वरीय चिकित्सकों के प्रति भी बहुत मैं राज्य सरकार की तरफ से आभार व्यक्त करता हूं। आज के इस कार्यक्रम में हमारे एडिशनल चीफ सेक्रेटरी आदरणीय अरुण सिंह जी, हमारे NHM के डायरेक्टर रविकांत शुक्ला जी, ऑल इंडिया मेडिकल एसोसिएशन के अध्यक्ष डॉक्टर जयलाल, ऑनरेबल ऑल इंडिया मेडिकल एसोसिएशन के महामंत्री डॉक्टर जयेश लेले, हमारी बहन डॉक्टर सुधा और यशोदा, और हमारे झारखंड प्रांत के ऑल इंडिया मेडिकल एसोसिएशन के अध्यक्ष बड़े भाई अरुण सिंह जी, महामंत्री बड़े भाई प्रदीप जी, और जमशेदपुर से अभी बातचीत कर रहे डॉक्टर दिवाकर जी। मैं सभी चिकित्सकों की बहुत गंभीरता पूर्वक बातों को सुन रहा था, और जिस तरीके से कोविड-19 का एक अभिशाप पूरी दुनिया के सामने प्रस्तुत हुआ है, और फर्स्ट वेव को हमने देखा। हमारे एडिशनल चीफ सेक्रेटरी साहब ने कहा कि फर्स्ट वेव से कई ज्यादा गुना सीवियर सेकेंड वेव था, और जैसे जैसे दुनिया के वैज्ञानिकों ने आशंका व्यक्त की है, थर्ड वेव के आने की संभावनाएं व्यक्त की हैं, और इस बात की तरफ भी ध्यान आकृष्ट किया है कि इसकी विभीषिका छोटे बच्चों पर और अल्पवयस्कों पर पड़ने की संभावनाओं की तरफ ध्यान आकृष्ट किया है। और निश्चित तौर पर हम माननीय मुख्यमंत्री जी के नेतृत्व में लगातार इस दिशा में कारगर रूप से काम कर रहे हैं, और प्रयास कर रहे हैं कि दिन प्रतिदिन हमारे अंदर जो कमी खामी है उसको दूर करते हुए हम कैसे बेहतर प्रबंधन के साथ बेहतर स्वास्थ्य सेवा उपलब्ध कराएं, इस दिशा पर हम बहुत मजबूती से आगे बढ़ रहे हैं। और जब दुनिया के बड़े चिकित्सक, WHO के डॉक्टर्स, अमेरिका में बैठे इतने बड़े बड़े डॉक्टर्स जो रात को अपनी नींद को त्याग कर झारखंड की जनता के प्रति इतनी संवेदनशीलता बरतते हैं, तो उस दिशा में राज्य सरकार का दायित्व और गंभीर और गहरा हो जाता है। डॉक्टर रवि कश्यप ने बहुत ही बेहतरीन तरीके से कोविड-19 की तीसरी विभीषिका के बारे में हम कैसे करके टीकाकरण कराएं, टीकाकरण से क्या लाभ होंगे, टीकाकरण की क्या आयु होगी, वो सारी चीजों पर बहुत गंभीरता पूर्वक प्रकाश डाला है। इसी के साथ हम मास्क का कैसे प्रयोग करें, सोशल डिस्टेंसिंग के नियम का कैसे पालन करें, और थर्ड वेव में जो बच्चों पर विशेष करके MICU मिशी के कुप्रभाव को हम कैसे कम करेंगे, उस दिशा में भी गंभीरता पूर्वक प्रकाश डाला है। और साथ ही साथ हम बेहतर कैसे PICU के प्रबंधन को आगे कारगर रूप से कदम उठाएंगे, इसकी भी उन्होंने चर्चा की है। साथ ही साथ इस दिशा में कैसे हमारे पैथ लैब को और मजबूत किया जाएगा, ताकि हम बेहतर तरीके से इनिशियल रूप से हम जो भी दिक्कतें आएंगी उन दिक्कतों को कैसे हम पकड़ेंगे, इस दिशा में भी उन्होंने ध्यान हमको दिलाया है। और उसी के साथ लो डोज एस्प्रिन का कैसे इस्तेमाल करना है आदि विषय पर ध्यान उन्होंने दिलाया है। दूसरी तरफ मैं हमारी डॉक्टर योजा बुलेट की बातों को सुन रहा था। उन्होंने माइल्ड, मॉडरेट, सीवियर, क्रिटिकल कोविड-19 की स्थितियों के बारे में विस्तार से वर्णन की है कि कब किस परिस्थितियों में हमको किस तरीके से बेहतर प्रबंधन करना है, इस ओर उन्होंने ध्यान दिलाया है। और ऐसे बच्चे जिन बच्चों में ब्लड डिसऑर्डर जैसे थैलेसीमिया है या और तरह के उनके बॉडी के इम्यूनिटी पावर कम होते हैं, वैसे बच्चों में किस तरीके से इसका कुप्रभाव पड़ता है, उस दिशा में उन्होंने हमको इंगित किया है। और इसी के साथ जो है कोविड-19 के सिम्टम क्या होंगे और उस पर भी चर्चा उन्होंने की है। मैं सभी लोगों की बातों को बहुत ध्यान से सुन रहा था कि किस तरीके से कैसी जांच करनी है, और जांच जो है चाहे वो सीबीसी हो, चाहे सीआरपी हो, चाहे डी डाइमर हो, इत्यादि से किस तरीके से हमको जांच करनी है, इस दिशा पर उन्होंने बहुत बेहतरीन तरीके से कहा। साथ ही साथ मास वेंटिलेटर, ऑक्सीजन के प्रयोग पर भी विस्तार पूर्वक उन्होंने बात कही है। हाई फ्लोरजल नेजुला कैनुला, वाईपेप, सीपेप मशीन द्वारा ऑक्सीजन थेरेपी, और किस तरीके से आगे चल के एस्टेरॉइड और आईजीआईवी का इस्तेमाल करने के लिए हमको बताया है कि जब एकदम विपरीत परिस्थितियां हो जाएंगी तभी हम जो है एस्टेरॉइड और आईजीआईवी का इस्तेमाल करें, और उसके पहले पहले जितना हो सके हम ये प्रयास करें कि हम कम से कम, क्योंकि हम लोगों ने कोविड-19 के दूसरे चक्र को भी देखा, और उस चक्र में ये भी देखा कि जो हमने जिस तरीके से एस्टेरॉइड वगैरह का प्रयोग किया, न्यूटन की गति का तीसरा नियम है क्रिया के विरुद्ध प्रतिक्रिया, और प्रतिक्रिया के रूप में ब्लैक फंगस और व्हाइट फंगस सामने आए। और जब बच्चों का इलाज हो तो हमको और ज्यादा बेहद सावधानी और बेहतरीन प्रबंधन के साथ आगे बढ़ने की आवश्यकता है। इसलिए जब तक, चूंकि इसमें एक चीज और भी बहुत सामने आई है कि इसमें कार्डिया की बड़ी समस्या आगे चल के होती है, और इस पर विशेष करके हमको कार्डिया के बारे में लगातार 3 प्रतिदिन या 12 घंटे या 24 घंटे में उस बच्चे को, यदि हमको ये महसूस हो रहा है कि बच्चा जो है MIC मिक्सी के रोग से ग्रसित है, तो हमको उसके कार्डिया के बारे में भी उसकी जानकारी लेनी है और उस पर जो है जांच करते रहना है। ऐसी व्यवस्थाओं के बारे में आपके द्वारा वरीय चिकित्सकों ने ध्यान आकृष्ट किया है। इसी के साथ जो है डॉक्टर पूजा कश्यप जी ने कोविड-19 की स्थिति में अधिकतर समय लक्षण प्रतिलक्षित नहीं होते थे। जैसे पूर्व में भी हम लोगों ने देखा कि बहुत सारे लोग जो है कोविड-1 में भी, कोविड-2 में भी हमने ये देखा कि बच्चे जो है, बड़े लोग भी एसिम्प्टोमेटिक होते थे, माइल्ड सिम्प्टोमेटिक होते थे। और चूंकि मैं तो चिकित्सक भी नहीं हूं और इसका विधि विशेषज्ञ भी नहीं हूं, लेकिन फिर भी मुझे ये प्रतीत होता है कि जो कोविड-1 और 2 भी आया है, उसका भी कहीं ना कहीं बच्चों पर कहीं ना कहीं दुष्परिणाम जरूर पड़ा है। लेकिन चूंकि बच्चों की प्रतिरोधात्मक क्षमता और उनके अंदर की इस बीमारी के विरुद्ध लड़ने में उनकी जो अंदर की बॉडी की जो क्षमता थी, उस क्षमता ने कहीं ना कहीं उस दुष्प्रभाव पर इन पर असर कम हुआ। लेकिन चूंकि अभी हमारे राज्य में 1,43,49,680 बच्चे हैं, और उसमें से 7 लाख बच्चों पर इसके दुष्प्रभाव पड़ने की आशंकाएं व्यक्त की जा रही हैं। तो ऐसी परिस्थितियों में हमको बेहद कुशल प्रबंधन के साथ आप जैसे वरीय चिकित्सकों के अनुभव, आप जैसे वरीय चिकित्सकों के दिशा निर्देश पर बहुत बहुत बेहतरीन तरीके से काम करने की आवश्यकता है। इसलिए मैं ये मानता हूं कि आज का ये जो वेबिनार है ये बहुत ही महत्वपूर्ण है, और इसलिए महत्वपूर्ण है क्योंकि जो आने वाला समय है, क्योंकि हम सारे लोग जानते हैं कि वायरस जो है वो अपने आकार प्रकार को बदलते रह रहा है, और वैसे तो निर्जीव है, लेकिन जैसे ही वो जीवित सेल में प्रवेश कर रहा है वो तुरंत जो है इफेक्टिव हो जा रहा है। और अभी तक हम केवल सुरक्षात्मक दृष्टिकोण से वैक्सीन जो है, हम उसको वैक्सीन को इसका सशक्त माध्यम मान रहे हैं, लेकिन अभी तक इसके निस्तारीकरण के लिए, इसके विनाश के लिए अभी तक हमारे पास वैज्ञानिकों के द्वारा कोई बड़ी दवाई का इजाद नहीं हुआ है। जो वायरस के संपूर्ण नाश या वायरस के समाप्ति का एक कारगर माध्यम हो। और ये जो वैक्सीन है, कुछ चिकित्सकों की बातों को मैं सुन रहा था, इस वैक्सीन की भी उन्होंने आयु के बारे में भी बताया है कि आयु भी इसकी कोई बहुत दीर्घकालीन आयु नहीं है। ये एक जो है एक फेज है कि कुछ समय तक हम अपनी बॉडी की प्रतिरोधात्मक क्षमता जो है वैक्सीन के माध्यम से उसको बढ़ाकर इस विपरीत परिस्थिति में अपने शरीर को लड़ने लायक बना रहे हैं। लेकिन इसमें मैं समझता हूं कि कहीं पर अभी तक ये नहीं हुआ कि हम इस वायरस के समूल नष्ट के लिए कोई ऐसी दवाई हमने नहीं इजाद कर ली है जो हमेशा हमेशा जो है परमानेंटली जो है, जो ये जैसे पोलियो वगैरह की दवाइयां आई हैं, टीके कर आए हैं, उसे धीरे धीरे हम पूरी दुनिया से पोलियो जो है नाश कर रहे हैं। तो मुझे नहीं लगता है कि इस तरह की अभी तक कोई व्यवस्था हुई है। लेकिन हाँ, सुरक्षात्मक दृष्टिकोण से हम लोगों को जरूर इस पर जो है विचार करने की जरूरत है। और हम जरूर इसमें जो है डॉक्टर दिवाकर साहब ने भी इसके डायग्नोसिस और इसकी जो है क्लिनिकल इसमें इफेक्ट के बारे में सवाल किया है। मैं डॉक्टर दिवाकर को भी बहुत धन्यवाद देता हूं। ये डॉक्टर दिवाकर जैसे हमारे बहुत सारे इस राज्य में चिकित्सक हैं जो चाहते हैं कि दिन प्रतिदिन जो है उनकी जो है इच्छा शक्ति बहुत बेहतर है। और मैं तो आप सभी लोगों को बहुत धन्यवाद दूंगा, ऑल इंडिया मेडिकल एसोसिएशन के आदरणीय अध्यक्ष जी, राष्ट्रीय अध्यक्ष डॉक्टर जय लाल जी को और महामंत्री जय लेले जी को कि आप अभी हम लोगों ने डॉक्टर डे मनाया है। और मैं उनकी बात को सुन रहा था कि उन्होंने एक दो सवाल किए थे, क्लिनिकल इस्टेब्लिशमेंट एक्ट के लिए और एक जो है मेडिकल प्रोटेक्शन एक्ट के लिए। मैं डॉक्टर साहब आपको इतना जरूर, हमारे माननीय मुख्यमंत्री जी के तरफ से इतना जरूर आपको विश्वास देना चाहता हूं कि हम लोग उस विचारधारा के लोग हैं कि यदि हमारे चिकित्सकों पर यदि किसी भी अपराधी ने या दबंग लोगों ने या अनावश्यक किसी ने भी हमारे चिकित्सकों पर कोई भी अत्याचार किया तो हम ये मान के चलेंगे कि वो राज्य सरकार के ऊपर जो है वो बदनुमा दाग लगा रहे हैं और राज्य सरकार के ऊपर प्रश्न लगा रहे हैं। और उन चिकित्सकों पर हमला नहीं, बल्कि ये हमला हम मानेंगे कि राज्य सरकार पर हमला है। इसलिए हम कड़ा से कड़ा कदम उठाएंगे, क्योंकि हमारे मुख्यमंत्री जी का भी मानना है, हमारा भी मानना है कि हम चिकित्सकों के चेहरे पर मुस्कान लाना चाहते हैं और उनके मुस्कुराते हुए चेहरे से ही हम अपने राज्य के मरीजों के चेहरे पर खुशी की लहर देखेंगे। इसलिए आप चिंता न करें, हम मेडिकल प्रोटेक्शन एक्ट के लिए भी गंभीर हैं और क्लिनिकल एस्टेब्लिशमेंट एक्ट में भी जो कमी खामियां हैं और जो त्रुटियां हैं उस पर भी हम जो है एक हाई प्रोफाइल कमिटी जो है, हमारे माननीय एडिशनल चीफ सेक्रेटरी साहब बेहद समझदार और बेहद कुशल प्रबंधक हैं, उनके अध्यक्षता में हम एक चिकित्सकों की और कुछ वरीय आईएसओ की और साथ में कुछ विधि विशेषज्ञों की एक कमेटी का फॉर्मेशन करेंगे जो इन सारी चीजों पर मेडिकल प्रोटेक्शन एक्ट से लेकर क्लिनिकल इस्टेब्लिशमेंट एक्ट में क्या कमी खामी है और कैसे हम मेडिकल प्रोटेक्शन एक्ट को कैसे लागू करें, उन सभी विषय पर हम लोग गंभीरता पूर्वक विचार करने के लिए एक कमेटी का फॉर्मेशन करेंगे। मैं ये आपको विश्वास देने आया हूं और ये मुझे बहुत उम्मीद है कि हमारे ऑल इंडिया मेडिकल एसोसिएशन के अध्यक्ष जी, महामंत्री जी, हमारे राज्य के अध्यक्ष अरुण सिंह जी, प्रदीप जी और चिकित्सक हमारे राज्य के साथ बहुत ही सहानुभूति पूर्वक विचार रखते हैं और निश्चित तौर पर आपके आशीर्वाद और आपके विचार और आपके अच्छे सुझावों का हम जो है आत्मसात करेंगे और हम सारे लोग मिलकर इस कोरोना के इस तीसरी विभीषिका जो आने वाली है इसके विरुद्ध हम लड़ेंगे। हम लड़कर इस विभीषिका समाप्ति करने की दिशा में कारगर कदम उठाएंगे। मैं एक बार पुनः जो है हार्दिक बहुत बहुत धन्यवाद देता हूँ, बहुत बहुत उनको आभार व्यक्त करता हूँ कि वो एकदम नए नए इनोवेशन के साथ राज्य की जनता के सुख दुख के साथ, चाहे वो सर्वाइकल कैंसर की बात हो, चाहे वो आई डोनेशन की बात हो, मैंने हमेशा उनको पॉजिटिव थॉट पर और बिना थके और बिना हारते हुए देखा है। तो मैं उम्मीद करता हूं कि आपके और हमारे मिलन से निश्चित तौर पर हमारे राज्य की जनता को एक बड़ा फायदा होगा, और जो आपने जो सुझाव वगैरह दिए हैं उन सुझावों का हम बहुत बेहतर तरीके से अनुसरण करेंगे, और अनुसरण करके हम राज्य की जनता को इस विभीषिका से मुक्त करेंगे। आज के इस वेबिनार के लिए मैं बहुत बहुत आपको धन्यवाद देता हूं, बहुत बधाई देता हूं, शुभकामना देता हूं, और आशा उम्मीद करता हूं कि हम सारे लोग मिलकर मानवता की रक्षा करने के लिए हम सारे लोगों ने, और विशेष करके जो हमारे चिकित्सक शहीद हुए हैं उनके प्रति भी हम बहुत आत्मा से उनके प्रति आदर करते हैं, और वो योद्धा हैं, और उनको जो है कहीं कहीं थोड़ी ये सूचनाएं हैं कि उनको जो है केंद्र के द्वारा जो इंश्योरेंस पॉलिसी पर कहीं पर थोड़ी कमी खामी है, उस पर भी राज्य सरकार गंभीरता पूर्वक लगी हुई है, और हम अपने राज्य की तरफ से भी हम अपने कोरोना योद्धाओं को कुछ ना कुछ अच्छा इंसेंटिव देने पर भी विचार रखते हैं, और उनको सम्मान के रूप में उनको अपने योद्धा के रूप में चिन्हित भी कर रहे हैं। आपको आज के वेबिनार पर बहुत बहुत धन्यवाद, बहुत बहुत शुक्रिया, और बहुत ही मैं आपके प्रति आभार व्यक्त करता हूं दिल से कि आप लोगों ने बहुत वक्त दिया है, और बहुत ज्यादा मैं धन्यवाद तो देता हूं डॉक्टर रवि कश्यप जी को, डॉक्टर पूजा कश्यप जी को, और योजा बुलेट मैम को, कि आप रात को 2:30 बजे आपने अपना हॉलीडे को भी जो है कुर्बान किया है और राज्य सरकार के ऊपर एहसान किया है। बहुत बहुत धन्यवाद, बहुत बहुत शुक्रिया।
Dr. Yonja, sir, honorable sir is thankful. He is sending thanks. Are you listening?
Thank you. I am. I don't understand some of it, but of course, thank you.
Okay, but you could understand a part. Dr. Pooja will convey. Pooja, he is very thankful to you, Dr. Ravi.
Yes, very much so. Thank you. Thank you. I really appreciate it. Thank you. Thank you.
And now, before I invite Mission Director NHM Shri Ravi Shankar Shukla, I must appreciate his vision that he has recorded the entire episode, and it will be available on the YouTube, which would be shared soon, so that all the doctors who have been connected, they can visualize it, watch it. And the doctors who have, because of some duty or some other reason, have not joined, they can watch it. So now I invite Mission Director NHF, Shri Ravi Shankar Shukla, who is a young dynamic IS officer, for vote of thanks.
Well, first of all, I would like to thank Dr. Bharti Kashyap, Chairperson, Women's Doctor Wing, Indian Medical Association, Jharkhand, for her coordination in the organization of this important workshop symposium on COVID-19 third wave, wherein international as well as national participants could both attend and share their thoughts. I would also like to thank the National President of Indian Medical Association, Dr. J.A. Jailal, for his perspective on COVID-19. I would also like to thank Dr. Jayesh Lele for depicting the efforts of medical practitioners during COVID-19 pandemic. I would also like to thank our Additional Chief Secretary, Sir, Dr. Sri Arun Kumar Singh, Sir, for underlying the efforts of the state government and the health department during COVID-19 pandemic, and also for highlighting the preparedness in the light of possible third wave in the state. I would also like to thank our international speakers, Dr. Ravi Kashyap, Associate Medical Director, Medical Intensive Care Unit, University of Illinois, USA, for his discourse on COVID-19 third wave and for his suggestions with respect to prevention as well as possible ways to overcome the same. I would also like to thank Dr. Yonja Bulut, Professor of Pediatrics, Division of Pediatric Critical Care, Department of Pediatrics at University of California and LA, for her views on acute COVID-19 and MIS-C in children. And as rightly pointed out by her, that in case of MIS-C, timely and early detection and early diagnosis, along with proper medical care, is going to be very crucial. I would also like to thank Dr. Pooja Kashyap, a pediatric cardiologist from University of Texas, USA, for highlighting the cardiologist point of view for COVID-19 in children. It is very important that the cardiac involvement in COVID-19 and differences between MIS-C and Kawasaki disease are highlighted, and it was a great opportunity for all the participants to learn about these fine details. I'm also thankful to our Honorable Health Minister, Government of Jharkhand, for his kind use, for his precious time to both address this symposium and at the same time to guide all the participants, for his inspiration and for his motivation and untiring efforts during the entire COVID-19 pandemic. Thank you, sir. I also take this opportunity to thank all the representatives from NHM and Health Department at the state level as well as at district level, all the participants, both from the government sector as well as from the private sector. It is very important that we all are prepared and well aware of the international scenario, international situation. This will help us a long way in being prepared and in giving a better response to any possible third wave or any possible surge of COVID-19. Once again, I'm thankful to all the participants, all the attendants. And sir, with your kind permission, now we can close this symposium.
हो गया